Why don't we go ahead and get started? So since all the presenters are hiding back here, just like the normal happens, everybody's in the back of the room. I'm going to start back here. So what I wanted to start with just kind of a quick introduction of us, and then kind of also get an idea of who's here in the room. So just so everybody knows, this is a Clerkship Director Bootcamp. Hopefully everybody's in the right location. So I'm Joe House. I am the Clerkship Director at University of Michigan. I've actually been in that role for 10 years now. I think this is the 5th or 6th year we've done the boot camp. So I don't know if Matt, you want to go ahead?
Sure.
Hello, I'm Matt Malone. I am the Associate Director of Advanced Management and Hospital-Based Care, which is a combined emergency medicine and sub-internship clerkship at Ohio State. It's really weird how they do it, but I spend about 80% of my time with doing EM stuff, mostly assessment. And then about 20% of my time is with the mini-Is, or the sub-internships.
Hi everyone, I'm Luan Lawson. I was previously a clerkship director for many years at East Carolina University, and I'm currently the Senior Associate Dean for Medical Education and Student Affairs at Virginia Commonwealth.
Hi everyone, good morning. I am Sharon Bord, and I am Clerkship and Sub-Internship Director at Johns Hopkins.
Hello, I am Kendra Parekh. I was the Clerkship Director at Vanderbilt for the past 9 years. I'm now Vice Chair for Education and Assistant Dean for UME.
Hello, I'm Donna Okoli. I'm one of the Medical Education Fellows at University of Michigan, and I'm also one of the Assistant Clerkship Directors.
I'm Kevin Hodges, and I'm the Vice Chair for Emergency Medicine at the Washington State University College of Medicine.
Good morning, everyone. My name is McKaylin Wolf. I am a rising third year at Southern Illinois University School of Medicine. I'm here to glean some pearls about clerkship and what I can do to be the best when I start those here in a few short months.
Hi, I'm Jessica Diaz. I'm a fourth year from the University of Arizona College of Medicine in Tucson. I'm also a medical student ambassador for this conference. So if you need any help during the session or anything, feel free to reach out to me.
Morning, everyone. I'm Julianne Jett. I'm the Simulation Fellow at Prisma Health Midlands in Columbia, South Carolina.
Hi, everyone. I'm Josh Glasser. I'm the Clerkship Director at Penn State.
I'm Chris Branham. Nice to see you guys. From Kaiser Permanente, Northern California Emergency Medicine. I'm Clerkship Director.
Hey, I'm Alondra Palma. I'm the Clerkship Director at the University of Chicago.
Hi there, I'm Bob Semberg. I'm the ultrasound director at Cleveland Clinic Akron General, and I have a little mini ultrasound clerkship. So,
good morning, everyone. I'm Spencer. I'm one of the clerkship directors at South Brooklyn Health.
Hi, everyone. My name is Adeline Dozwa, and I'm the fourth year acting internship director at Carolinas Medical Center in Charlotte.
Hi, I'm Danny Matonis. I'm at UC Irvine. I'm the clerkship director for our sub-I and our required fourth year clerkship.
Hello, Allie Dory. I'm from the University of Utah, and I'm the fourth year required clerkship director.
Rowan Kellner, also from the University of Utah. I'm the medical education fellow.
So just get a sense, like who's been, it's actually a fair amount, who's the actual clerkship director? Who's been for longer than 5 years? Okay, good. So a lot of people who are on the newer side. So hopefully you'll learn a little bit about multiple topics, LCME, the slow, some of the mistreatment stuff, and we can kind of go through some of our experience with it, unfortunately. But we're going to go ahead and get started.
All right, so first to get started with is the lecture dead. And so we'll talk about some active learning strategies. So who has some type of lecture and or classroom-based activity in their clerkship? So it looks like pretty much almost everyone. And so what is active learning? This is the active part.
Say what you're doing now.
Yeah.
Incorporating questions into the didactic, I guess, making people think.
Incorporating questions, trying to make people think. Yeah. What else? Simulation. Yeah, so really anything that sort of like guides the learner and actually gets them to do the work, where you're not just like, spoon feeding everything to them. And so we often talk about like the sage on the stage, right, which is like very teacher-centered, which is like, very, usually more large audiences, some kind of expert just talking, versus kind of this more idea of like guide on the side, which is more learner-centered, where really the learner is the focus, and you're just there to kind of assist, facilitate, and coach them in their learning. And I think it's important to remember, right, like learning is a process that happens in someone's brain. Like we can't see learning, we can't make someone learn. Like we have products of learning and we use tests or other assignments to help try and infer if learning has actually occurred. But really it's a mental process that occurs within the learner. And so really what we're trying to do is create maximal conditions for learning to support their learning. And we want to try and be active because not just do we want them to get material, right, but you also want to help them learn how to learn, because none of us practiced the same way we did when we sat in our fourth year, Clerkship's learning this information, or even at the end of residency, like we have to continually learn, so we have to teach our students how to do that as well. So classroom-based teaching, right, it's helpful. You just need to deliver information, get a solid knowledge base. Maybe you need to explain difficult concepts. Students in general struggle with an area, so having them all together to kind of talk about it can be helpful. Higher order thinking stuff, and facilitating transfer, and this is really big. So really helping them take what they may already know, make connections, and then apply it to a new problem or situation. And you can also build other skills, right, like collaboration, communication, and develop some shared understanding and expectations. And so it's not all bad, right, to have lectures. And also this idea of teaching people how to learn. And so we're missing some general principles of instructional design, like whatever you say you want them to do, like that's the strategy that you want to use. So there should be congruence between your objectives and the strategies you're using to help achieve them. You want to try and use multiple strategies and think about your resources. So sometimes people get really excited, they're like, I'm going to make this very active, right? And you just start like throwing in all this stuff, and you've got like a poll and a case and a simulation, right? But I just want to encourage you to be like thoughtful, right? Like make sure what you're picking, like sometimes we get really excited about a piece of technology or a strategy. Like just make sure it makes sense in what you're actually doing. And so what we'll kind of walk through is like some like really quick kind of like add-ons that you can do, some more extensive like integration into lecture, and then if you just want to get rid of lectures altogether. And so as we move through, if you guys have any experience with any of these things, thoughts, comments, please do just like raise your hand and shout out so we can share and learn from each other. So some quick things are using pause procedures. So this can be relatively low tech, like an index card, so like the muddiest point, right? Like at the end of the session, you just ask everybody to write down what was the most confusing thing to you, what question do you still have. Some people do the burning question, like what are you most curious about after hearing this talk? You can also do like the 1-minute paper, like what are the 2 things that you really remember from this talk? And that helps you as an educator, because then you read all these things and you're like, oh, like they really got the things that I was hoping they would get, or wow, this is not what I was thinking they were going to take away from this. And it gives the learner just a moment to pause and reflect on what they learned, which can be pretty powerful. Doing some case-based scenarios, right, telling a story usually makes people more interested, and when you can show that clinical relevance, particularly for medical student learners, that's also really helpful. So commitment exercises, right, like we did one in the beginning, like introducing yourself, or if I said, who has a mandatory M3 clerkship, right, or how do you feel about active learning? Like anything that tries to get those learners to invest in what you're saying. And there's lots of like low-tech ways, like hands in a small group. I've done it with like different colored either index cards or like sticky notes for people to like raise the sticky notes, how they feel. There's online versions, there's poll everywhere. Kahoot is another fun one, and then Mentimeter is another great one to do it. Concept maps, these can be pretty fun, asking students, to think about, shortness of breath, right, and sort of map out all the different ways and problems associated with that. Anything that gets them to kind of use what you're trying to teach. And then social media, depending on your program and school's policies, but that can also be a fun way, or if you have an online learning management system like Canva or something, like can you use the forums or other discussion places to help get the students engaged. Anybody use any of these and have an experience they want to share? Like a pearl or a pitfall? Yeah?
You pull everywhere quite a bit.
pull everywhere.
lectures, but, and they just did an improvement. They said that there's always a gap between your lecture or your PowerPoint, whether it's embedded or not, you know, and then accessing it.
Yes.
So they say they've improved it, I'll see.
Okay, yeah. And so some quick additions, think, pair, share, right? This is pretty common. Like you give people a question, they think about it, and then they pair off with someone, talk about it, and then they pair with a large, or share with a large group. And this is really helpful, particularly if you have like introverted learners, because it gives them a time to kind of process that information in a smaller way before sharing out to a large group. Role play, like people usually have like a love-hate relationship with role play, right? I think it definitely has its place. I do a lot of teaching about like coaching or feedback. I think it's really hard to do an effective session without having like some type of role play or some type of practice. So I think it needs to stay in our arsenal. Debates can be pretty, pretty fun to get people engaged in having dialogue. And again, not just about like what are they learning about like the medicine or the content, but right, it also teaches them how to have dialogue, how to respectfully disagree, and what that looks like, and how to resolve conflict. Educational games, we have like it's called Emergency. It's like a game board where they get to build a little ED, and we simulate 24 hours of care, right? And it teaches about systems science, it teaches about all kinds of things, and they love it because they start to compete, like who's going to make the most money, right? Like who's getting the most patients. But they're really invested. And so there's lots of different educational, games out there, or just gamifying something you're like already doing can be very motivating. And then snowball. This is kind of fun, particularly if you like need people to like get up and move, just because maybe they've been like sitting for a while. I recently did this with a learning objectives lecture, teaching students how to write learning objectives, right? Like not like their favorite thing in the world, right? And so like I had them write their objective on an index card, and then they folded it out. They all like threw them into the center of the room, and they all got up, and they had to pick one and edit it and make room again. And so it was a lot of fun. It generated a lot of energy around something that otherwise might have been a little more dry. Any pearls or pitfalls from the audience on anybody that's using any of these? All right. So move on to like lecture alternatives. So this is like you're at like I don't want to give any lectures. So what can I do? And so these take a lot more like investment time, resources. You can't just take your lecture and make it into a flipped classroom thing to do it well. And so flipped classroom, apologize, the actual text isn't showing, but there's pre-work, there's classroom work, and there's post-work. And so the pre-work is really where the student's supposed to be learning the content. It's asynchronous, it's independent. I would say one, if you're gonna do this, make sure that you have time for the pre-work, because what I've seen some people do, which is a pitfall, is they're like, I'm just gonna turn everything into flipped classroom, right? But then you don't account for the time that the learner actually needs to like go through the material, or you don't hold them accountable for that material. And so either they're like working way more than you had intended because they're trying to do all this, asynchronous learning, or they're not doing it at all. And then they come to the classroom session and you're trying to apply and synthesize and make this cooperative activity, and you quickly realize like no one has actually done the pre-work. And so then you have to give a mini lecture anyway. And then oftentimes we forget the post-work. So really for the full flipped classroom model for it to be most effective, and how it's been studied is it's like pre-work, classroom work, and then post-work. So some type of deeper learning or synthesis. Does anybody use like the flipped classroom model? Yeah, any other pearls or pitfalls that you have about it?
I think you hit it on the head, the hold them accountable for it, because I see somewhere between maybe 10 and 20% of people complete pre-work. You hold them back for the majority who did not, or you leave 80% behind, I don't know.
Then you're like different learner levels in the same audience trying to manage it.
Have you ever considered, or has anybody ever like scheduled time to actually do the pre-work, like students to come at 8?
That's what we come at 9. Yeah, that's what we do now. We have flip sessions. We build it into the schedule, so it's like self-directed learning. And so we have the time, and then they can we encourage them to use it for this, and it's blocked out after that. The other thing I found helpful is to make like the pre-work more active and engaging. So like using some other stimuli other than like PowerPoint slides are not like great for this. And sometimes that's what people do. They take their lecture and they put the PowerPoint slides in. So like we sometimes use other stimuli and give them like a guided reading sheet or like a worksheet to sort of fill out so that and then they turn the worksheet in so they're actually engaging engaging with that pre-work material, and then there's some type of product that we can hold them accountable to when it comes time to come to the flipped classroom. The next one is team-based learning, and so a lot of schools use this in like first year curricula, and so it's kind of similar. There's the preparation phase, which is a very, again, individual phase, guided learning done independently. Then you take a readiness assessment test. There's an individual test, and then as the name implies, team-based learning. You have a team, so you take an individual test, you take a team test, and then there's some discussion or learning of material. And then there's an application exercise, again, done in individuals, done as teams, and then a class discussion. And so this really tries to assess like what each individual understands and knows, and then how that changes when they come together as a team. And for the most part, everyone's individual test scores are lower, right, than when they have the team test score. So this can be a fun way. Does anybody use team-based learning? Yeah. Any pearls of wisdom for us?
It's similar to getting people to engage with that prep and the pre-reading. This year we're doing we took a TDL and adapted it. So they're making weekly quizzes. So they're pre-reading for it. They take a little quiz. And then when they come in, there's a group activity. I have a few colleagues for a huge gamification.
Okay.
So we kind of turned it into like a little game. So we're hoping that. And then our reading, we've tried for like you can read it, you can listen to the podcast. Like, however you like to digest it, go for it. So we'll see what comes.
The multiple options kind of to get through the work, but again, that sort of accountability piece for actually doing the work beforehand.
I mean, I'm just thinking back to my med school experience of like problem-based learning, I guess, similar, a little different. And
That's our next one. Yeah.
Sort of universally reviled just because people, I think, just at least in this med school setting, wanted to just like get the facts they need to know for the test and like that. But I haven't had too much experience in sort of a higher level stuff, and I don't know how people's experience has been with those learners.
Yeah, so that's actually, it was a good segue. So like the next one is problem-based learning or case-based learning, where you kind of start with a problem or with an unknown case, and then the group of learners, usually with a facilitator, kind of walk through the case, they think about what they don't know, and then they kind of learn and apply it. And so I think we use some case-based learning in our senior courses, and our whole first year also has case-based learning in it. And so I think the students, for the most part, really enjoy it. That being said, they do their own sort of learning objective work. The facilitators are trained to kind of keep them on track, so they will like sort of be like, this is like really interesting, it sounds very curious, but like, how about this? So that they don't run too far off the path. And then they always get like the intended learning objectives at the end. And so that I think helps a lot, because then they know like this is what we took out of it. This is really was the intent, and they're held to the like what the intended objectives for the case were. And again, I think it also like a modality that provides a good opportunity to see like, well, like how did we end up down this like down this rabbit hole, or like how do these things compare? And if we were really off track, like what was it about the team dynamics, or how did we sort of get off track? And so trying to teach them those higher also like metacognitive skills for them, so they're not just learning content, but also like learning how to learn.
Can you give an example of one of these?
Yeah. So the way we have it structured, it's they get the case on like Monday. So they all read through like kind of a couple page sort of case with some lab data. Then they come together on Wednesday and they kind of talk about the case. They think about what they want to do. They think about like what questions they have, and then they all sort of assign each other things to look up. And then they come back on Friday and they all sort of bring together what they found, and then they reach like resolution of the case, and then they get kind of like what was the intended learning from the case. Does that help? Yes.
Is this for EM clerkships, or are you talking about like clerkships across the third and fourth year at your university?
So both. So our whole first year curriculum uses not problem-based, but case-based learning, and then we have some case-based learning in some of our EM courses. We have more than just like a clerkship. We have some other like mixed foundational science courses that we use it in.
But this is also used like when you do like surgery, IM, EM at your university, or just talking about EM here?
No, other of our clerkships will also use case-based learning. Yes, that's correct.
Yeah, I was just going to say my school is completely problem-based learning through years 1 and years 2. And from a student perspective, I think it does hold us accountable more so for content, because you know that you're coming into that next session with the purpose of talking about a specific topic and sharing that knowledge with your classmates, but then we're also integrating that clinical aspect. Most of our facilitators are MDs that work in the hospital across the street that we do our rotations with, and so making that connection early on. And actually, I will do my EM clerkship with one who facilitated my group. So it really does come full circle, and from a student perspective, I've really enjoyed it.
Actually, kind of had a similar question in how much of this is baked into your EM clerkship, and if so, how do you find the time? You commented on something where you have free work on Monday and then come together on Wednesday, come together on Friday. How do you, what do you, or anybody actually, what do you actually balance with the shift work that we ask students to do? And depending on how many teacher resources you have, the shift work is also.
Yeah, so for us, it's not in our core clerkship. We have another course that students take that's more like 50-50 classroom sim time and clinical time. And so it's easier to find the time to do this in that space. I think if you were going to do it like in a clerkship, you could probably do like a multi-week sort of thing, like maybe, you know, have them do something like Monday, Wednesday, and then come back together on Monday and then schedule like shifts around it. Like if you had some kind of like some resident didactics where you have some set times that they're together and then trying to do it that way, or do it asynchronously, like have them post some stuff in discussion forums, or trying to work offline a bit together and then bring them all back together. But you probably couldn't do like 4 cases like one week or anything a lot of time.
Just to add, this type of learning is really important for students, because I find that students oftentimes just don't know how to think about problems, and like we do this on a daily basis with other patients we see. They come to us with a problem, we have to ask some type of curiosity about what's going on, we do an investigation, we get some results, and it refines the process. I feel like in our broader scope, that's what students have difficulty doing. So finding ways to kind of incorporate this, but also just scope it for the student, like let them know why this is important before you just dive into cases. To make these exercises really powerful.
Great. All right. So now it's the think, pair, share time. So you guys, I'll encourage you just to think about an activity in your clerkship or whatever is within your sphere of educational influence, and think about if there's just one thing you'd like to do to maybe modify that activity to make it more active learning for the students. How are we doing on time? Okay. So we'll give you a few minutes to do that, and then we'll have you share it to your tables. And so we'll take about two minutes or so and just think about it, jot it down. If you write it down, you're more likely to commit to it, and then we're going to share it verbally with your colleagues to increase the level of commitment. And so, yeah, we'll come back together in a few minutes to talk about it.
That's why it's not showing up. If you did that like 10 so I just want to
Do you have people that are coming in to do this?
Yeah. I don't think the font are black. So all these ones are missing.
So I'd love to like make sure that standards is lectures, but yes, I would.
Help them with getting my clerkship is only 2 weeks, so it's not really time to do a, multi-day or multi-stage kind of thing. I can see, the thing that we're really struggling with right now is we're trying to like social determinants of harm, substance use disorder, some activity around those issues. We have it, they just identify like a patient with social needs. Yeah, so we, like, I'm doing like, mostly like, trouble with that, but so like, we don't, like, everybody is so like, you ask, like,
I don't know, most likely come back. For some reason, for whatever reason, you back to, yeah, in my school, there's that like, we were just like, scary, like, that's how it's yeah, maybe it's like,
I'm wondering if like you could do some
Right.
problem-based learning kind of thing where we present, made up I know this is basically softball, but sorry.
Just like, it's all. Yeah. Yeah.
All right. Okay, we'll come back together now. So I heard lots of discussion. So does anybody want to share an idea that they're thinking about to build in some more active learning into their educational experience for students? Yeah.
So one of the things that our students don't particularly like in previous years is they have to do like kind of like this interprofessional education. It's almost like a reading and writing assignment. And they don't get a lot out of it, and they don't put a lot of effort into it. So we're switching that up, and now we're doing a combined interprofessional simulation with the College of Nursing in the third Thursday of the Clerkship. That's focused on sort of communication and collaboration. It's like a code situation.
Mm-hmm. Yeah,
We
great.
piloted it in January pretty good.
Yeah, so taking it out of the classroom completely. Yeah. Other thoughts that people had, or other questions that came up when you were thinking about it?
I was just saying to my group that we, for our clerkship, we've had a like shadowing experience with crisis social workers for our students that has been very unpopular. It just feels like low yield to them. And, but this like maybe a problem-based learning kind of process that we could use for that instead. And I'm trying to figure out how to replace that activity with something that will be more, useful to the students. But, so that's what I was thinking was just, can we create, a patient case or something that they like read beforehand and then they think about it on their own and then we can move together and talk about it as a group. And we actually have some social workers in the community who are willing to help us with this course and actually come to our orientation and talk about it, about these issues. So maybe getting them to come in and provide an educational piece to the learners about like, here are the resources that might be available for this case, this patient, and maybe that could kind of branch out into other resources, additional resources that are available.
thinking like, what would we do for the follow-up session, but I think, you know, tagged on to the ultrasound sessions, and they all have to be in person for the ultrasound session too. I don't know if anybody has any ideas about something to do for the second session.
Maybe they could investigate a community resource, like, you know, like depending what your case was, you could have them look up and then talk about a resource in the community. Maybe one potential thing, or if you did have them go on, still do their shift, but maybe did like a little like scavenger hunt, or gave them some like specific aims to look for that maybe they could then like apply back to that sort of case at the end. And so using this as kind of almost like a pre-work for that observation. And so you were like, okay, like find 3 communication skills or 1 resource or whatever, that kind of thing with a little bingo or something, you know, something fun, like game it up a little. Then maybe they could come back and share about those experiences and how, what they learned from that and how it could relate to the case. Yeah, great. Anybody else with any other thoughts, ideas?
Thinking about this, depending on what your effort, time provided by the school, you may have limited, resources and community lessons. So leveraging national curriculums, we talked about the foundations as a medical student course, and then also obviously the SAEM kind of going through, just integrating that with either as pre-work or
Yeah, and that's great. Figuring out what's already like, you don't have to reinvent the wheel for everything, but like just kind of curating that information and sending students to it, to some good quality information. That's great. All right. So any other questions about active learning? And even if you like are like, we don't have any classroom-based anything, like even if they're just doing shifts, like active learning would be asking them to just make up a goal, like a learning goal for the shift, or a follow-up, to your point earlier, right? Like a follow-up question from the shift that they can then present to the team. Like anything that just directly engages the student a little bit more. Any questions? So you guys are also stuck with me for the next little bit. So we're going to shift gears a little bit, and we're going to talk about planning for non-EM-bound students. And so how many of you are required to get students that are both like EM-bound and non-EM-bound? So it looks like almost everybody. Is anybody just fully elective? Yeah.
I say we're like, students are required to do 2 acting internships, so we get a lot of students that don't want to do an acting internship that's like, I don't know, surgery, that come to us for their second one.
Okay, so slightly interested because it's maybe better than some alternatives, but not, yeah. All right, that's perfect. And so how do you all feel about non-EM-bound? I already see some head shaking.
They're harder to engage.
Harder to engage, yes.
They're hard to care about.
Hard to care about. All right, great. Any other thoughts? Let's put them all out there.
In my area, they come in at the end of the academic season.
Oh, yeah.
And especially those M4s that are just trying to get through their questions, who they have already mastered or are about to match. Keeping engagement stuff.
Keeping engagement, yes. This is all great. And so what we're going to do is discuss the benefits of having non-EM-bound students in your rotation, so why it's beneficial to you, and kind of develop a systematic plan to help really maximize the experience of those students, much of which revolves around engagement. And so some key things, just being proactive. So like, I know for me sometimes it's like, oh, this is going to be miserable, so I try not to think about it, right? And I'm like, I'll just deal with it when it happens. And so I encourage you to like be a little bit proactive in how to manage it. Really trying to think about just kind of like flipping the script. And so maybe it's not so much as like, these are going to be problematic, or I know what this is going to look like, but here's an opportunity for me to grow as an educator. Like, where's my growing edge in all this? What can I learn about myself? What can I educator skills can I help try and develop to manage this? And then ultimately cultivate a desire for these students to really figure out how they can sort of benefit your own personal growth as well as EM in general. And so this is a highly unscientific graph based purely on my personal experience, but this has been my experience. And so like, we have motivation versus time. And so usually M3s like just coming out, maybe they don't know what they want to do, maybe very focused on the grades, and they usually have a lot of motivation, so it's not difficult to keep them engaged. It just kind of generally slides right into that inflection point that you mentioned, that sort of like M4, And then there's sometimes this little uptick when there's the panic, right? Like, oh my gosh, I'm gonna be like a doctor soon, right? So we can capitalize on that, and we can use that. And so, what are the benefits of having non-inbound students? And so, for you as a clerkship director, so first, I think it's a great opportunity to influence specialty selection, right? Like, we want, competent, caring individuals to come into our specialty. And so, many students, right? You all know this, like. It's based on their interactions with the people, how they feel in that rotation, that really, really influences them. And so trying to think of this as an opportunity to bring the students that we really want in our specialty into the fold, to show them, hey, this could be your career, this is what it will look like. To impact their view of emergency medicine. So really, we touch so many other parts of the healthcare system, and regardless of what specialty that those students end up going into, they're going to interface with us. And so I feel like we have a responsibility to show them what life is really like in the emergency departments. I mean, you don't call them back right away because you're doing a resuscitation or you've got all these other things to manage. There's some sense of understanding of what the true role of the emergency department is within the healthcare system, and really that downstream effect that we feel like when you discharge, when surgeries are scheduled, all that stuff impacts the emergency department. So wherever they practice in the hospital, by practicing thoughtfully, right, and trying to have that broader system view, can really impact care that patients get in the ED. To promote collaboration, right? Oftentimes, we had this year, we had the largest number of students ever stay at our institution for a match. And so those students that were in the course as fourth-year medical students are going to be my consultants in July, right? And so, you're going to see some of these learners again. And so really trying to build collaborative relationships and helping them be better consultants, help them be better future consultants, help them understand what that side of the equation needs to look like to facilitate your workflow. Oh yeah.
Sorry, I'm just giving you this microphone for records.
Oh, okay, great.
No problem.
Okay, now I have to use the microphone because it's recording. And then lastly, it does provide a seat at the table, right? So if you are a required rotation, that gives you political capital within your School of Medicine, which can be helpful in terms of advocating for resources and for change as well. And so it can just be important to help advance our specialty and visualization at that level. And it's also good for the students, right? And so patient care, how many times are they seeing undifferentiated patients, right? I work in I don't even know, a quaternary, maybe, I don't know what the next level is, right? It's oh, it's Monday and it's the right kidney that hurts, let's page this service, right? And the students oftentimes are on those specialty services. So emergency medicine may be one of the few times they're really seeing undifferentiated patients. And so they may know, right, a ton about aortic dissection, and they may have even done a repair, but when that patient comes in with chest pain, they have no idea how to tell if it's aortic dissection or not. And so this is that opportunity. Lets them perform focus histories and physicals, differentials, procedures, urgent interventions, and if your school uses the entrustable professional activities at all, like EPA 10, which is recognize and initiate initial treatment for an emergent or urgent situation, this is great fodder for emergency medicine. Systems-based practice, right? Prioritizing tasks. We see, right, so many patients over and over. So it's a great opportunity for them to practice. So you can give them feedback, they can apply it, they can practice, and see how it changes for them. And there's lots of health system science. So if your school has a curriculum on or interest in health system science, the ED is such a great place to bring those things to light. There's so many processes, there's the whole healthcare system, interprofessional education, teams, collaboration. And then practice-based learning, recognition of limits, we all know is hugely important. And so the ED is a great place because we all know what looks like a stable patient from triage. You may walk into the room and that may not be the situation that's happened. And so helping foster that in students, learning it's okay to ask for help and learning how to do that. And so a systematic plan to manage. And so this is kind of how I think of learning, right? There's the teacher, there's the learner, there's some type of social interaction that occurs between them, and ideally some learning. And it all happens within the learning environment. So thinking about ways that we can kind of influence each of these different areas. And so as the teacher, I think two important things are having clear expectations and also having a good attitude. Using learner-centered approaches, optimizing the learning environment, and then fostering some intrinsic motivation. And I put that one last because it's probably one of the harder ones to do, but I still think it's kind of something that we have to keep trying at. And so expectations, this is for both the clinical and the non-clinical components. And so make sure that both the students know and all the people interacting with the students know what those expectations are. And this includes like process expectations too. I think sometimes it's really easy to forget how overwhelming the emergency department can be because we work there all the time. And so like showing students like where to sit, where to go to the bathroom, just all these basic things to try and take some of that uncertainty and chaos out of the environment can be really helpful. Make sure they understand what the expectations are for the course. And I found it's helpful to give a bit of a primer on like how emergency physicians think. Because a lot of students, right, may have done a lot of inpatient or they've done a lot of outpatient. They tend to have like wellness bias and, you know, they don't really like understand like you have to be a medical pessimist and like that's what we need from you. And so really trying to help them see why that's important and really verbalize that to them. And then help them see these translatable skills and the benefits. So like I will like just tell them, I will be like, hey, here's all the great things you're gonna do in emergency medicine and here's how it's gonna help you be a better neurosurgeon, a better, you know, ophthalmologist, whatever it is. And asking them what they wanna learn can also be really helpful. And reminding them that they often have families and friends and they're gonna call them, right? Even though they're whatever person practicing whatever specialty, like their friends are still gonna call them and say, you're a doctor, what do I do? And so emergency medicine can be super helpful for that. And always inspect what you expect. And so I think nothing undermines expectations faster than when students aren't doing what you've asked and no one tells them, right? Like if you need them to complete things, you need them to do shift logs, whatever it is, like making sure that you're holding them accountable. And similarly, it's not fair of us if we have hidden expectations that we don't tell the students and that we're like angry that they didn't do the thing. And so whenever I get angry because the student didn't do the thing, I'm like, did I tell them that that was something they were supposed to do, right? And so also holding ourselves accountable. Have a positive attitude, be open, approachable. I think, you know, just being enthusiastic for our specialty, for what you do. Practice mutual respect, right? Like just treating students with respect, knowing their names, using their names. Acknowledge their past experiences, because a lot of times, you know, we may have students that have had other life experiences that bring actually a lot to bear to the team. And if you don't sort of get to know them or allow them an opportunity or create an environment where they feel comfortable expressing that, that knowledge may not actually come forth during those interactions. Acknowledge their presence, right? That's like just like a big one, like saying hello, making sure people are seeing that the student is there, and then expecting competence. I think a lot of times, you know, we may just expect to show up and not sure what to expect, but really just expecting competence and supporting that learner's autonomy and independence as they're going through their education. Use learner-centered approaches, very similar, right, to active learning, but designed for shifts. Get to know your students, plan and encourage self-directed learning, like you all mentioned earlier. Like maintain some type of resource for students, or if you have your own teaching files or departmental files, but really encouraging them, like, oh, hey, we just talked about this chest pain patient, why don't you go do X, Y, or Z, and having a place for them to go. If there's an opportunity, I think, you know, allowing some individualization of the curriculum can be really helpful to capture some students who may not be like primarily interested in emergency medicine, but maybe what can they learn about within the sphere that's of interest to them. And then that usually opens up their curiosity enough that they're more receptive to what you also want them to get out of the rotation. Do you have different pods or different sites? Could they, you know, self-select for slightly more time in one versus the other based on their interest? Can they select some didactic or self-directed material? Anything to kind of recognize their own interests can be really helpful. And then use bedside teaching techniques that get the students' thoughts first, right? So there's lots of these. 1-minute preceptor snaps are some of the most popular, but anything that gets the student talking so you know what they're thinking before you tell them will help keep them engaged. the learnable moment, right? Like we talk a lot about the teachable moment, which is like when we as the teacher are like ready to like spew forth our knowledge onto others and like give these pearls. But really I would encourage you to think about like the learnable moment. So when is your learner actually ready to learn? And so really kind of paying attention to that, because they're gonna learn better if they're primed for learning and they're ready for learning, not just when you're like ready to teach to them. Any questions so far, or any like advice on any of these things that people want to give?
Wondering, I'm thinking like for us, I feel like a big part of what we've been trying to do with our course is definitely to impact students' view of emergency medicine. I will say when we were getting the course approved by the School of Medicine, I sat in, I'm a member of the fourth year curriculum committee, and so I sat in and listened to some comments from some student members of the committee. And I was very impressed by their lack of enthusiasm for the course. I mean, one student said, I'm going into neurosurgery and I consult on patients in the emergency department all the time, so I know how it works. Which, you know, obviously they do not. Yeah. So I just like, I'm curious if people have thoughts about other things that they've done that have been helpful, that they have felt was helpful to sort of change the way that students think about emergency medicine, like language that they've used or things that they've used in their orientation lectures. You know, I can't really change what my colleagues do on shift that much. I mean, I send emails regularly asking them to do this and that, but you know, if there's anything specifically in your orientation lectures or in any activities that you do that are specifically directed at that point. Question I had.
Since we're recording, I'll ask y'all to use the microphone.
A couple of ways that I work that in is where essentially a required rotation, students are required to take 2 AIs, and EM is often one of them. 2 ways that I've worked that in, though. One is we use a evidence-based medicine blog post piece to sort of teach EBM. And in orientation, I always recommend that the people who aren't going to be emergency physicians learn about points of tension with the ED. I always sort of tease the future family physicians and say, tell me about the literature behind asymptomatic hypertension from the EM perspective and the family physician perspective. And I've learned a ton from budding ophthalmologists, and you know, how have you been taught to manage this, and how has the ED been taught to manage it? But then I make them write up and bring me some primary literature. And the other, I use a simulation-based curriculum as well, and do 1 sim session a week. And I always tend to sort of dictate at least my initial story based on where the majority of learners are going to be. You know, the code doesn't have to come into the ED. It can be your floor patient as an intern starts looking like this, and you're going to have to deal with this for everybody except, you know, the pathologists. And so that's helped as well.
I was going to make another comment about having students come from other specialties, or students who think that they're going into other specialties. So for our rotation, you can rotate from like your first to your very last rotation. And every year, or about every year, we have students who thought they wanted to do something else, who then do their emergency medicine rotation and say like, oh my goodness, I'm so surprised, I really love this. I've had students who do it as their very first rotation like ever in med school, who didn't think they were gonna like it at all. They were doing it just to like get it out of the way. And then they realized that they really actually love it. So I think that you had mentioned this in your talk, one of the best things about having all the students come rotate with you from like who think they're interested in different specialties, I think that it's a wonderful way to kind of highlight how wonderful our specialty is, and to sometimes bring students over or have them realize that this is a career that maybe they were thinking about.
So this is our pause for reflection, and then hopefully we'll get some more ideas for you too as we move through. And so I would just, if it feels okay for you, just take a moment and think about like your worst rotation, like in medical school. Like, what were you doing? What were the people around you doing? How are you feeling? And what made it feel so bad? Anybody want to share what made it, you don't have to share the experience, but what made it feel bad?
It's still fresh in my memory because I'm a fourth year, finish all the required clerkship. It was a rotation where we were, well, I'm just gonna say it was OB. And I was basically like ignored. And they knew I wanted to go into EM. And I try to be honest, at that point I was like, I like EM, but I'm still open to, seeing what specialty I end up in, which was honest. But they heard that and they immediately were just like, okay. And at my school it's academic, so it's like you're with residents. But even then, attendings didn't even know my name. Like I would just sit outside of the call room, and they all went in there. And I was just sitting there, and then someone's like, what are you doing out here? I'm like, well, I'm waiting for my residents. They're like, oh, you should just go in there. And I'm like, I don't think I can go in there. And then they're like, why didn't you just come in? So it's like making sure that your student, whatever specialty, feels included, is not in the way. At least in EM, we don't say anticipate the needs of the ER and not tell us what is expected of us. I think that's really important to not make your student feel like they're not integral to your team, they're dumb, they can't read your mind. So I think that was really not fun of a rotation.
Well, I'm very sorry that happened. It is very illustrative. Anyone else? Any other additional thoughts to add? And I think that's a really, a good example, and brings us really to the learning environment. And so if we think about the example that you bravely shared with us, right? Do we do that to our students if we know they're going into whatever? Do we sort of dismiss them slightly in our minds? Do we only point them towards cases that align with their future specialty? And so really trying to think about how to create that positive learning environment and thinking about our professional humor. We have a really hard job, and so sometimes we make jokes, but sometimes those jokes for students or others that don't have the context or understanding can come across not the way we actually intend. And so just being thoughtful about what we're portraying, when and how we're using humor. And actions speak louder than words, right? So you can stand up in front of all your students and give this great list of expectations and all these things, but if that's not the lived experience, when the student gets to the shift and they are ignored, or they're told, oh, don't worry, don't write that H&P, or you can just come watch, don't go see that patient on your own, that misalignment will sink the greatest of expectations that you may have very clearly set out. And so just reminding everybody, you're role models for students, and when you think they're not watching, right, I promise they are. They see and they hear everything. And so just empowering others to kind of recognize that status that they have. And so how do we then try and foster some intrinsic motivation? And so, it was a cool little gear slide. But really, there's lots of theories on motivation out there, but they really all have kind of three things in common. And the first is really, can I do it? Which is self-efficacy. Do they feel confident? Do they have the sense that they're going to be able to do the thing? Do I want to do it, right? This is task value. Is this something that's important to me, important to what I want to do? And then lastly, what will happen if I do it? Which is task expectancy. And so really for our non-EM bound students, we can try and intervene at each of these levels, right? So maybe it's encouraging someone that they can do a procedure and linking them to a YouTube video to watch, or some other resource, and then helping them see the value. And so helping that neurosurgeon that doesn't understand, I already know how the ED works, helping them see the value in what you're asking them to do and how it's going to make them a better, whatever it is that they want to be. And then what happens if they do it? And so we're rather than read more or improve your test scores, right? It's about having a broader knowledge base so that you can make faster decisions at the bedside, or so that you have a broader differential when you go into the room and you can do a more focused history and physical. So really being specific and helping those learners understand why these skills are important. lastly, thinking about like mastery orientation and growth, like really giving people permission to like try and fail, obviously in a way that's like safe for the patient and simulation or discussion. Rewarding growth, like I think a lot of times, right, like when we give grades, it's like this average over the whole course, right? Who if someone comes in and they're super amazing and they leave your course and they're super amazing, like have they learned anything? Like, I don't know, maybe. But if someone comes in and, you know, maybe they're struggling in an area and they get feedback and they use that feedback and they show improvement, right? Like I think we need to make sure we also are recognizing that. And thinking about growth-oriented feedback and emphasizing why, again, like why all the things are in the course, they're all there for a reason, and helping people see that. And so here's a case. You've just come on for a night shift and the department's busy. You notice a student sitting in the workroom checking email on the computer. You get pulled into a sick trauma resuscitation, and when you return to the workroom, the student is still there with the email open. So how do you handle the situation, and what can you do to prevent similar situations in the future? I'll let you guys discuss at your tables, and we can come back together.
Like, wherever I go, you have access to go. And that was something that she was comfortable doing. So then whenever something was urgent to come in like that, I already felt invited. You know, it wasn't outside the room to step in and obviously step in. But I can still be there and learn. And then once I was already in the room without her having prompted me, it was, hey, email me. I was like, and so it was integrating me with little things like that that made me feel like I had a purpose there. So instead of just like shadowing kind of a thing, you know, she set very clear expectations from the beginning, like, listen, it's gonna get crazy in here, there's something wrong with you know, all of my residents are in education, follow me, something happens, go. They gave me a lot of kind of like autonomy in that, like I have access to HR, the board, and also just being very open about it. Like we all, I like it actually, and just each other, like, see what it is. You can talk about what you know for the residents, to find things. So I feel like in my experience, this is being completely like transparent with them, like, yeah, I just have to follow you, you know, or if you get hung up in another, you know, whatever, that's okay. And just having that transparency of what they do.
So that's their I know. That's why that's our textbook. That's like the most area. All the shit that you say during the I knew you want to do it anyway. So I get comments like that, where they left you early, or they didn't stand up to you. And so maybe like actually having another or not even stay out of the way, but just like are you aware? Oh, I'm just yeah. Which I totally I feel that this is representative. Yeah. But I mean, just letting them know that I'm
I know. Let's say like next, we're actually going to go back to 2020 to find this thing. It wasn't even in 2020. It was like that.
So are non-year with our residents?
All right, so we'll kind of come back together. So, any thoughts on how you would handle the situation? What would you do?
We talked a little bit about about is this just a knowledge gap for the student, right? Did the student not know that a sick patient came in? So could this be a teaching moment to say like, hey, you know, when they called overhead this trauma code 2, that's what this means. So it's a teaching moment for the student, but also I think for yourself to remember to like grab it, like, hey, you hear that overhead? That meant that's trauma code 2. Let's go.
Yeah, great. So not making any assumptions, first off, about why the student's on the email, right? And learners do well when they can. So if they're not meeting your expectations, you know, maybe they just don't know or understand. And yeah, I tell all of our students at orientation, I'm like, look, like you can go to anything that you want. I promise you, someone will tell you not to be there. And if you see or heard of people going with purpose, like follow them, right? Like, because something is happening. And so giving that permission at the onset to like go and be within the department and not having to wait for that permission to get up, and then being more explicit and saying, oh, hey, maybe, you know, these overhead pages, did you hear it, right? Maybe they didn't even hear it, but you want to listen out for them, and this is what they mean, and this is what you should do when you hear it. So great, yeah. Other thoughts about this one?
Just fostering that open, positive environment where learning is encouraged. And so actively grabbing them and bringing them to that area and say, hey, listen, be involved in any way you can, be encouraging in that aspect and help them. Maybe they just don't know, you know.
So being really encouraging.
Also, sometimes if you see a student just sitting there with their email or like studying, they're also trying not to like annoy you and get in the way when something busy is happening. So that's also another thing, you know, like it's not that they are ignoring you or, you know, don't want to be involved, but they also sometimes like, I'll show up to a shift, they'll be like, oh, it's really crazy, the attending has to get a lot of sign out, just wait. And so you're just sitting there like, you know, when do I jump in so I'm not seen as annoying and bothering them, or, you know, so that could also be another thing.
Yeah, and it goes back to not making assumptions, right? So if you need to ask the student, like, you know, like it's not, why are you on your email, right? It's like, I've noticed that you've been on your email, and then you know, kind of creating space for, you know, for that response, just noting what you observed. I did this one time, I was on shift, and there was like a student who was just like constantly on their phone, and I was like, I get it, like I'm old, I'm not like trying not to be on my phone all the time, but I felt like this was like even like just like a bit obsessive, and I was like, I noticed that you've really been on your phone for a large part of the shift, and I haven't seen you really participating in our board rounds. And they were just like, oh, do you want to know what I've been doing? And I'm like, yes, right? And like they had looked up all this evidence, right? Like they were like an MD PhD student, and they had all these guidelines, and they were trying to understand like why we did this thing instead of that. And I was like, okay, you now know a lot more than I do about what's going on with this situation, but right, like, and so had I just been like, you know, don't be on your phone, right? Like I would have taken that learning away from the student and myself, because I did learn some great things from the student who was engaging in patient care in a way that felt familiar to them, and they felt like they were helping the team. And so really just kind of being open to that. All right. So to bring it home, having non-EM bound students can be beneficial to you as the director, the students, as well as to our specialty. Think about a plan to how to really help maximize learning, and whatever you do for non-EM bound students is also going to help your EM bound students. So this is not like a either or situation. So setting and communicating clear expectations, even for small things that you may take for granted, like what to do when you hear the trauma call, how to participate during sign out, when to best to contact your attending. Have a good attitude, use learner-centered approaches, think about the learning environment, and I know we'll hear more later about that as well, and then really think about how to foster that motivation. So, all right, any other questions or concluding thoughts about this? All right, thank you.
So Matt, if you want to go ahead and cut up. Yeah, so I apologize for some of the slide issues. Google doesn't like to play with slides very well. So there might be a couple other people who have some blank slides in there, and I apologize. Except for this one. If there's any blank slides, he uploaded himself, so you can blame him. You just stand up here, you want the mic.
I'll stand up here, but the mic, if there's a interactive part that I'll need the mic for.
I have it off right now.
Okay. How do I turn it on?
There.
Hello, how's everybody doing? So today we're going to talk about the learning environment, which I'm sure everyone is familiar with because we all went to medical school, and as clerkship directors, we should know how to optimize it. So learning objectives today, we're going to define what the learning environment is based on the standard 3 of the LCME. We're going to describe positive and negative features of a potential learning environment and some training mistreatment cases, and identify some strategies to improve and optimize the learning environment. This. So the learning environment is the structural and social context where the learner does their learning. It influences their behavior, emotions, and their performance. The learning climate, on the other hand, is how the students experience and perceive the learning environment, which can even if a learning environment is identical between two students, their perception of that experience is probably going to be different. There are elements of the learning environment that you can control and some that you have less control or potentially even no control over. The things that you probably can, that can contribute to the learning environment that you can control would be things like the skill of your teachers, the size of the groups, the learning materials and methods that you're using, the schedule of educational activities, things like that. So you may have some control over this, you may not. But there are other things that are probably within the realm of the control from the student's perspective that you may not actually have any control over, such as when the student last ate, what their study skills are like, the neighborhood that they live in and have to get to school, their mode of transportation, their social relationships, all will affect how they perceive the learning environment and the experiences that they have. So if you're trying to create a ideal learning environment, some things that you would want to do is foster a mutual respect between you and your students, be friendly, cordial, and welcoming, create a trusting and safe environment, be engaging, supportive, and be student-oriented. And some things that these students may perceive as a negative learning environment would include things like poor communication of expectations during the clerkship, feeling like they don't have any power, in particular in my clerkship. That lack of empowerment is related to their clinical schedule, which I think has been causing us the biggest headache since interviews went virtual a few years ago. Any culture of fear, work responsibilities that don't involve any teaching, like scut work, disrespect from colleagues. It doesn't even have to be towards the student. If they, for instance, observe an attending disrespecting a nurse or a resident and in a situation that they have no involvement in, it can still really adversely impact their experience. And also if they have no control over what they can do about it. So if they receive, for instance, what they feel to be an unjust evaluation, like is there a procedure in place for dealing with that sort of thing, or some sort of excessive workload, either time or amount of work within the time that they are there. So briefly, we're going to talk about the LCME Standard 3, which covers the academic and learning environments. So in general, the LCME Standard 3 requires a medical school to ensure that that its educational programs occur in a professional, respectful, and intellectually stimulating academic and cultural environments, that it recognizes the benefits of diversity and promotes student attainment of competencies required of a future physician. Sounds easy, right? So we're going to go over each of these, I think, 5 or 6 substandards. These are definitely things that you should know if you have a required clerkship. If it's, if it's elective, it may not be as valuable for you to be aware of this. And also just note that a lot of these standards have to be met from like a global level and may not necessarily be directly impacting your clerkship. So LCME standard 3.1 requires that residents, that the medical students participate in one or more required clinical experiences conducted in a setting where they work with residents enrolled in an accredited GME program. That does not necessarily mean that your clerkship has to have, or the students in your clerkship have to be working with residents directly. We run several sites at OSU where they're community sites and they work directly with attendings. But at some point in their 3rd and 4th year, they have to work with residents, and this might be their opportunity. In addition, the medical education program is conducted in an environment that fosters an intellectual challenge and spirit of inquiry, appropriate to community of scholars, and provides sufficient opportunity, encouragement, and support for medical students participating in research and other scholarly activities of its faculty. So again, this is a big global perspective. You don't necessarily have to have research incorporated into your clerkship, but it does have to be somewhere in the medical school curriculum. 3.3 is the medical school has to have an effective policy and practice in place that engages ongoing systematic and focused recruitment and retention activities to achieve mission-appropriate diversity outcomes amongst its students, faculty, senior administrative staff, and other relevant members of the academic community. And these activities should be aimed at achieving diversity among qualified applicants for medical school admissions, et cetera. So despite the recent Supreme Court ruling on this, this has stayed in the LCME standard, and I think they have a active policy on this. I was reading their policy from 2015. I don't know if it's been updated, but their website still has this policy. And similarly, you cannot discriminate on the basis of age, creed, gender identity, national origin, race, sex, or sexual orientation. So getting in, and this is, so at Ohio State, for 3.2, this is kind of how we do things. We have this MedPath program that is a diversity pipeline program for medical students. So the next 2 are the ones that are probably most applicable because they to you because they are applicable to every clerkship at your medical school. So 3.5, a medical school ensures that the learning environment is conducive to the ongoing development of explicit and appropriate professional behaviors in its medical students, faculty, and staff, and one in which all individuals are treated with respect. So most importantly, the medical school and its clinical affiliates are responsible for periodic evaluations of the learning environment in order to identify positive and negative influence on the maintenance of professional standards. So what does that mean for you? If you don't already, you need in your perhaps end of clerkship evaluation or somewhere within your end of shift evaluations, some sort of questions about the learning environment, including questions about student mistreatment, which I'm going to give you some examples here going forward. And the last standard is 3.6, also appropriate for your clerkship. The medical school defines and publicizes a code of conduct, professional conduct for faculty-student relationships in its medical education program, has a written policy to address violations of this code, and has effective mechanisms in place to respond to any complaints. In addition, you need a mechanism for reporting violations of the code that are well understood by the students and ensure that any violation can be registered and investigated without fear of retaliation. So you don't necessarily need to be the one that puts this code of conduct into place, but you should be aware of your institution, what their code of conduct says, and that you can help a student if they would like to report a violation of that code of conduct. So, as I said, the LCME requires us as clerkship directors to track this within our clerkship, and they're going to ask you about it at their site visit, whenever that is. So some examples of questions that you might want to put on your end of clerkship evaluation. Here are some examples from ours that I can share with you. So the faculty, healthcare team, and others on this assignment created an environment that promoted appropriate professional values. Students were treated with respect. Did you feel the supervision of you as a student in this course was sufficient to promote a safe environment for you and your patients? The teacher treated me with respect, and the teacher treated others with respect. So again, it's important to remember that a lot of the concerns that medical students have are witnessed encounters between various healthcare staff, faculty, residents, et cetera, and in situations that they aren't directly involved, but it still affects how they perceive their learning experience. So if you're interested in kind of understanding what types of mistreatment, what types of concerns medical students have, here's a really interesting article published by him that they go through a lot of this. Do you have any perspective from this particular, do you remember this publication? And
well, we kind of just went through and cataloged some of the complaints that we had, and kind of some of the ones you can control and some of those you can't necessarily. I guess I can use the mic. Some of those that we do have control over, and some of those that no matter what interventions we try, it seems like every couple of years they kind of pop up. That's kind of what we did, and making people aware of them, because that's the other thing is, a lot of times, and I think Kendra kind of brought this up a little bit too, is our faculty will say things, and it's in the emergency department, and they don't think anything of it. But then you have people who have not, kind of spent that time, and they hear something, and they're like, that's not okay, kind of thing. So again, just kind of keeping people aware of that, and that was one of the things that we did with this paper, is just like I said, kind of catalog some of the concerns that students had submitted.
Thanks. So at Ohio State, we have, in addition to our end of clerkship evaluation, we also have a anonymous or at least protected student mistreatment form, which we lovingly refer to as the big red button. And this is a way that students can they can kind of bypass your clerkship altogether and take it directly to the deans if they feel that it's an infringement that needs to be addressed at a higher level.
So one comment I'll make on that is we actually got cited because not enough students, when they did the review from the LCME, said that they knew how to submit it. So even though it had been on the website, even though it had been in multiple areas that had been brought up, we actually got cited because not enough students actually were aware of it. So every clerkship now has a slide that the med school put together, so everybody's got the exact same slide showing how to access it, and all the steps for it. So again, it's not just having it, but actually, again, you need students to say, yes, I am aware of this.
So in addition to what your medical school and or your specific clerkship how you track the learning environment. The AAMC graduation questionnaire also has several, if not many, questions on the learning environment. I'm not going to go through all of these. But in general, they've been collecting information since 1992. The questionnaire asks whether the students experienced any of several types of mistreatment, what the source of the mistreatment was, to whom they reported that mistreatment, if there was a satisfactory action taken regarding the mistreatment, and if they witnessed or reported the mistreatment of other medical students, staff, faculty, et cetera. If you are interested, you can just Google it and get essentially all of those questions. We're not going to go through all of these, but it's pretty extensive, and there's also some sort of fill-in-the-blank areas as well where they can sort of describe the experience that they had. So there's also some very specific types of mistreatment that I'd like to highlight because of their importance and because of the frequency that they come up. So one of them is the effect of gender on their clerkship experience. So it's important to not, when you're working with students or when others are working with students, to refrain from stereotyping roles, abilities, or specialty choice, because I think one of our medical students had already made a comment that that's a pretty frequently seen thing. It's like if someone is going into the specialty that you work in, you probably are going to have a different experience than someone going into psychiatry, surgery, family practice, et cetera. Any perceived differences in workplace relationships or favoritism because of this. Similarly, any discomfort due to a culture dominated by a specific gender. OBGYN has more women than men, I'm sure. Right now, I think in academics, we're 65-35, or either 65-35 or 55-45, something like that, somewhere in there in emergency medicine. So we're pretty balanced in terms of the gender split. And then any unsolicited sexual attention. So we're going to get into that specifically here. So in general, romantic relationships between individuals in a supervisory, teaching, evaluation, advising, coaching, or counseling relationship is considered a conflict of interest. It doesn't necessarily mean it's banned, but it definitely means that it needs to be mitigated. The person in the position of higher authority has the responsibility to eliminate that conflict of interest that minimize the potential for harming the person in the lower level of authority. So what that generally means is this is discouraged when it can be avoided and prohibited in certain situations. So if you happen to be married to a medical student, which is okay, you cannot work directly with that person. So is a little bit outside of the context, but one of our faculty is married to one of our residents and has been faculty since before that resident match. So they can't work directly together because of that conflict of interest. There should be a disclosure and management process related to this. And even if that conflict of interest is mitigated as much as possible, there are still risks that it can affect the student's experience. Similarly, sexual harassment, mistreatment based on gender, race, ethnicity, and sexual orientation are explicitly things that you are not supposed to do. I can't think of the word that I'm trying to think of. But all of this kind of falls under Title IX, so I'm sure that your institution may or may not, but probably does have some sort of learning module or annual type of education for faculty related to Title IX, because I think it's a requirement. Raise your hand if you've done one of these modules on a yearly basis. So, yeah. So, as I said, a lot of this stuff is not necessarily things that you will always be directly involved with, but stuff that you need to be aware of. Some other things, the other types of mistreatment that I wanted to talk about are things that may come across to you or the people that are making these, that are doing these mistreatments. They may not understand or recognize that they're doing it. And these include things like microaggressions, which are subtle but offensive comments or actions directed at a minority or non-dominant group that are often unintentional and they unconsciously reinforce stereotypes. Another one was that one of our medical students brought up is neglect, which is not benign. You know, if you're ignoring your medical student, they're probably not getting the quality of an educational experience that they would if they were not being ignored. The lack of civility between specialties, so the tribalism that comes with us creating work for consultants is super real, and minimizing that as much as we possibly can go a long way, because most of my students are not going into emergency medicine. So if I'm talking bad about a neurosurgeon or a gastroenterologist, even if they are not going into neurosurgery or gastroenterology, I can guarantee your medical students think to themselves, well, what do they think about the psychiatrist, or what do they think about the family medicine doctors who send, who can't see their patients in clinic and send them to the ED. And again, any of these marginalized groups can have mistreatment specifically because of their identity or their views. So I'm going to do some cases now, which are going to be interactive. And I think this is the fun part of the little lecture. So these are drawn from actual student reports at my institution, and I want your opinion on how to deal with them. All right, here's case one. You're hearing a medical student present on a case to a team of about a male patient who's HIV positive, and the resident asks the student if the patient is gay, and then asks, is he a pitcher or a catcher? And the student is visibly uncomfortable, says he doesn't know, and then chiding and kidding begins about guessing the answers kind of amongst the clinicians involved. You witness this. It may not have anything to do with you may not actually be taking care of this patient, but how would you address this? Don't all speak at once.
You gotta tell the resident that that's, as the attending, your responsibility is to intervene and show the professional side right away, both to the resident and to the student. Otherwise, the student sees the tacit approval of that. And this is you could categorize this as a microaggression, but that microaggression could result in inappropriate treatment or unacceptable treatment due to sexual orientation, which is not okay.
Exactly. So is the question that they're asking invalid, or is the way they're asking it wrong? That's one of the things that I get from this. Does anybody give me some feedback for this resident on how they might ask this question? One, should they be asking this question of the medical student? And two, how can they ask it in a more appropriate way?
I try in these scenarios that, like, I rephrase it, I then like start like asking the questions to the resident in a way that I think is like modeling the right behavior. And then I force, like, I'm now like pimping the resident, so now the resident has to answer all these questions, and I'm modeling that good behavior. And then I'm like, okay, now you can ask your student all these questions, and you guys can discuss. And then later I pull the resident aside, and I'm like, that's not appropriate, you can't do that. But it's partly, it's like when I want to intervene, demonstrate, like, that's not okay. And I might even, ideally I would say that in front of the student too, so they're seeing it. But then I have the more serious discussion with the resident by themselves.
Yeah, would you also have a sidebar with the medical student about this too?
Yeah, oh, absolutely. Yeah, to tell the medical student, I'm sorry that happened, that's not okay. I had the discussion with the resident as well, and it's just closing the loop with everybody. So it's pretty, like, this is not good.
Well, we'll get a worse one, I promise. Did you want to add something?
It's important that this be addressed in real time, because this is totally disrespectful. And I think you take the resident aside and you have a sidebar with the resident. And then I'd have a sidebar with the resident and the student, and I would personally apologize to the student for the inappropriateness of a resident. But I'm old school. I was, I trained in the early 80s when there was no EMTALA and no that sort of thing. But from an older person's perspective, I think that these things should be addressed in real time. And the resident should be called out on his inappropriateness, not in the group, but aside. And I think that we should apologize to the student in front of the resident for this inappropriate behavior.
So I'll ask a follow-up question. Does anybody think that this should be run up? Does anybody think that this should be run up the chain to the program leadership? Is it that egregious? So how do you know it's a pattern if nobody brings it up?
You don't. Yeah, I mean, I think, yeah. I mean, I guess it probably, in light of that question, maybe it should be, and it's someone else's job to see if these issues are accumulating or not, but.
So would you put it perhaps in their end of shift evaluation or end of shift assessment? Is that, nope, not there?
I'll also just say, I mean, I would back up and ask the question is this question even necessary for this case, right? So, like, I also think normalizing for a student, particularly if it's a younger learner, about why this information is important for this particular case. Like, how are you going to use this information to provide better care for this patient?
Yeah, I can certainly imagine clinical scenarios where this would be, a handful where it would be important to know. And many, many, many more where it would not, All right, well, we'll belabor.
Yep. So one thing I was going to add, just brought up, like, is it a big deal or pattern? Is so I actually encourage our students to, fill out that online form, and I tell them, like, if it's a little thing, that's fine. If it happens one time, I'll let the faculty or resident know, and just for feedback. But the only way to know if it's a pattern is to report it. Because I had one faculty member who was like very worried. It's like he'd gotten teaching awards, but he got one of these complaints, and it's like, it's happened one time. It's not, it's not going to be where you're now not going to be able to get promoted or whatever else. It's the pattern. So I always encourage students to report it, because that's the only way you're going to get those patterns.
All right, case 2. During sit-down rounds, the attending arrives a bit early. The resident's finishing up on an urgent consult isn't there yet. The attending gives the medical student a Starbucks card and asks him to get some coffee for the team, and as they finish up co-signing notes. So, is this appropriate? This is a divisive topic, I think. So the question becomes, where's the line? Hey, do you mind picking up my laundry on the way to work?
When it doesn't have anything to do with clinical care, it's like, even though, like, you're paying for the student's coffee too, that's where I draw the line personally. I know some people are like, well, I'm getting them coffee and we're busy, and like that. I'm like, it has nothing to do with clinical care. It's purely an errand.
Exactly. So the the graduation questionnaire does not explicitly have this question on it, but if you look at studies that have been done about medical student mistreatment, this is one of the things that they bring up pretty frequently, if not very often, is that they're asked to do non-clinical tasks or tasks that are unrelated to some sort of learning. So you may think that you are doing a nice thing. You're getting everybody coffee, and you're kind of having the team multitask, and everything's going to be a good experience, but it may not be. All right. Last question. A student on a colleague's team, so not one of your students, comes to you for advice. She stumbled on a presentation the other day, and the attending said something to the effect of, well, I suppose that's okay for a blonde. Today, he said, after seeing a bookish patient, the attending said, I bet you like nerdy guys, you probably like to dominate them. I suppose I shouldn't say anything, say everything I think. So this is not something that you have witnessed. This is third-person perspective. So how do you deal with this situation?
It's third-person perspective, but there's a paper trail of a text message. I think this probably jumps pretty straight up to medical school leadership.
Yeah.
I think there's a role for stepping in and interceding for the student, because I think a lot of times retaliation is a big concern for students, and so if you can kind of, play that role and intercede for them so that they don't feel the backlash of that and kind of help facilitate that.
You mentioned that this needs to go to medical school leadership, but I think also involving whoever the boss is of this colleague, whether that's the chair of the department or whoever their direct supervisor is, because if this person's saying these things to a medical student, they're probably also saying these things to other people, and there's probably a pattern that needs to be uncovered there.
Thanks. Yeah, I'd say it's also important to know that, even if it does need to go to medical student leadership or hospital leadership or whatever, that doesn't mean you send the student to the hospital leadership. There should be a no wrong door. Now that's your responsibility to make sure that that doesn't die with you.
So I think all of those are really great responses, and I will add only one thing. Does this would raise your hand if you think this falls under the realm of sexual harassment? What do we know about sexual harassment reporting? It's mandatory. And at your institution, you'll have, there will be some sort of process for this, but once it's in your brain and you know about it, you have to. It's not like you can't, this other person who saw it actually happen, they're required to report it too. So you and or them or both of you need to figure out the process at your institution of how to get that through.
We were just talking about this at our faculty meeting yesterday, and that even if the student or whoever you hear it from says, no, I don't want this to be reported, you still have to report it. You're obligated to. But the other thing I think that was interesting that we talked about in our meeting yesterday, and I don't think we really came to a conclusion about it, was like, how did the learner perceive the situation? And so there are some things that are said when they're taken out of the context, like they sound very off-putting. But then when you actually talk to the person who sort of was the recipient of that comment, they're sort of like, oh no, it was fine, I thought it was funny, or whatever. And so I think that's a difficult thing to kind of piece out. And I think these are pretty cut and dry cases, but like the times when what was said was actually perceived by the learner who's just mentioning it as like funny. I think it gets like a little bit more sticky and kind of complicated there.
With that, and that drives toward it contributes to a hostile learning environment. So if it's welcome, it's the old the old conundrum that if the advance is welcome, then it's not harassment, but it's any hostile learning environment. This is not a quid pro quo.
Yeah, so that goes back to the difference between the learning, and so it's probably contributing to a negative learning environment, but in that specific context might not, that student might not interpret it as such. All right, so we'll finish up here. So in summary, make sure all your learners are feel welcomed and included. Be respectful and civil. Kind of recognize that you're always on stage, which I think is how I would summarize this. Provide a mechanism for reporting and faculty feedback. Consider resilience training for your learners. The ED is a difficult environment. Get the faculty involved in this process. Nurture a common mission. Recognize good teachers and professional teachers. Any questions about all that? Yes, ma'am.
Yeah, this is not a question, but again, from the student perspective, something that my institution has done, starting with our first year, is a student abuse session in which our Dean of Student Affairs comes in with other figureheads within our institution, and they actually present a Slido. I don't know if anyone's familiar with that, where everybody joins on their phone. It's completely anonymous, and we go through instances of student abuse, and then the students vote on a scale, absolutely this was abusive, no, this was not, I'm not sure what this was. And so then it facilitates conversation about what is appropriate in these instances, because the students, we do want to, make our attendings happy and contribute to the learning environment, but you don't always know what that looks like. And so that's been something that's very helpful, I think. And during those sessions, they also provide us with all the resources on, okay, well, if something happened that's questionable, you're not really for sure, what do you do about it? And where do you actually go to report, more significant things that you definitely are sure, are abusive. But and it's something we repeat second year as well, so that we can see how our perspectives of it have changed, and then give our classmates an opportunity to share, what they've experienced if they're comfortable.
Anybody else have any questions or comments? Well, thank you very much.
Or why don't we go ahead and take a short break? So come back about 10 o'clock.
Wait a couple more minutes. Oh. Alrighty, we're gonna go ahead and get started. We're gonna do a quick little talk on medical student advising. Just a refresher, I'm Donna Okoli. I'm one of the medical education fellows at the University of Michigan, and also one of the assistant clerkship directors. So first, just want to ask you guys, what are the barriers that you have to student advising right now?
I feel like, especially students who are emergency medicine bound, I feel like all of my advice feels old now.
Mm-hmm.
And I'm not up to date enough on sort of what are the newest cool things that people are doing to augment this process, and a match for EM and applying for EM and all that stuff. And I also feel like the process keeps changing, and I don't necessarily know what all the up-to-date information is. So I guess that's for me is I'm just not, I can definitely talk to people very easily about, quality of life and lifestyle things, and EM as a career and that kind of stuff, and sort of the, helping them explore what their life goals are and that kind of stuff, but then the actual process feels a lot more nebulous, and sort of how to position themselves best for emergency medicine once they've decided that emergency medicine is what they want. That feels
Yeah.
I think occasionally there's information that isn't, they get different information from different groups, right? So the College of Medicine has its own reasons for advising. Like their end goal is 100% of students match. Then they'll get advice from other students, either former students or current students, and then they'll get advice from you, and not all of that advice is the same message.
So don't forget social media. All the great advice that comes
Reddit.
from Reddit.
Mm-hmm. Yeah. Yeah, so I think, the goal of this presentation is really advising students is an immense amount of effort. It's not easy, and I think each individual has their own story, and that also adds to the complexity. It's not like a one shoe fits every student. So really tailoring what the student actually needs to the advice that you're giving them, and also understanding that there's a bunch of other resources for advising, and how do you embrace that to help get your student to where they want to go, whether it's that specific program or whether it's just matching. So hopefully there's a little bit of something for everyone today. But I think big picture, it's more so that advising looks more so, it's more than just what you're doing around the match application cycle, especially for EM. A lot of students might not know that they want to go into emergency medicine, not have any exposure to it, and then that on top of the fact that we have like an interesting application cycle, like you need a specific letter of recommendation, you need to do outside away rotations, and making sure that students are set up for success from the beginning. So advising in the preclinical years, whether or not your institution has an emergency medicine interest group, and how you engage those students early on and making sure that they can be set up for success. Knowing that, sometimes students have a broad range of interests. So sometimes that student who comes into medical school knowing that they want to do EM, making sure that they're involved in EM specific activities. In different leadership opportunities. But then as you progress into the clinical years, making sure that even if their research is in something else or their interest has been in something else, like how do you bridge that and bring them kind of back into EM, can kind of develop that story for the students. And then specifically for the match cycle, making sure that students are successful on their away rotations, that they have adequate application prep, they're picking the right program for them specifically, and then how to succeed throughout the interview season, and then kind of what you're doing for your students post-match, or within that match period. So developing a rank list that looks right for them, prepping for residency, and just how to be successful as they transition into being an intern. So the emergency medicine interest group, I guess, like show of hands, which institutions have one of these? Cool. So how do you guys engage with your EMIGs right now? Yeah. Oh, is there anything specific you do with your EMIG, or is it just kind of they do their own thing and you show up when they ask you to?
We have like a specific faculty advisor who I think just helps coordinate the events and stuff. We mention that to like the set of things we do, or if we want to do anything extra, that's the person we reach out to. And then through EMIG, those going into EM are assigned a faculty advisor at the beginning of the third year. So they work directly with those students.
Anyone else?
I was going to say we're pretty similar set up, that we just kind of sign off their events and provide feedback. I kind of feel like they're adults, so they organize their own events, and, I'm here to just kind of guide them sometimes or give them ideas.
Yeah. I think the same thing kind of happens at the University of Michigan. They kind of run their own show, their own student club, but I think it's a really powerful opportunity to engage students early, especially those first and second year students who are kind of like, I don't really know if this is right for me. So really maximizing your opportunities in the EMIG. Of course, the students are organizing like their own EMS events, or if they want to have like IV clinics or student-run clinics, whatever they're doing, I think that's fine, but also making sure that like some critical things that you can do are having like a career mentorship panel, just so that students have face time with EM attendings and kind of get that nitty-gritty of like what it's like to be an EM physician. There's also opportunities to show them the different practice settings. So if it's like a community versus academic versus county kind of practice setting, just so that students have that idea of like it's not just one size fits all. And then also giving them opportunities to understand the different fellowships and the different like subspecialties within EM that they can go into. And then again, just making sure that there's like early application prep so that students know early on, like, hey, even if you're undifferentiated, you don't know what you want to go into, making sure that they know, at least prepare for having to do away rotations, even if you're still undecided. And then giving them some information about the SLO process. And then specifically when we're talking about EM-bound students, this is when your student has decided like this is what they want to do. I think there's kind of 3 critical-ish meetings that you can have with students, and that's before they actually get into their EM rotation. So this is kind of like a general intake session where you're figuring out who the student is, what they're interested in, why they've chosen EM, and then some like objective data on the student. So like what's their class rank, how did they do on step 1, or did they pass or fail? And then step 2, like what actual score did they get? What grades they've gotten on all of their clinical rotations? And then any like extra opportunities that they've been involved in terms of like leadership or research or what they're interested in. And then during the rotation, having like a mid-rotation feedback session. And so I think it's tough for the programs where it's every student at the institution goes through EM, but just making sure that you know your specific EM-bound students so that their feedback can be tailored to like, how did you do on this rotation? How are you gonna grow? What do you need to do to be set up to be successful on your away rotation so that you can get some good SLOs from that? And then for your students before they are submitting their residency applications. So like, are there opportunities for someone to go over their personal statement, opportunities to actually go over the application and like what were their important activities and how are those phrased? Just different application prep before they go into that process. And so I think it's a balance between like what is the objective data for your student, and then more specifically, like how are you helping your students kind of create their own unique story? I think students come from different backgrounds, they have different interests, they decide on EM at different points in their medical school career, but I think with advising, thinking about the student that we love to interview and the student that we want to recruit to our program, it's about how did you bring all of this together and form some type of like professional identity formation where it's like it makes sense as to who you are and like why you want to do this, regardless of if you did research in OB or if maybe you loved your internal medicine rotations and decided late in the game that you actually didn't want to do that. So focusing on those 2 things in your advising sessions, not just what the numbers say, but like who is the student and how are they crafting this story. And then like we talked about, there's a lot that can be done from the clerkship standpoint, but also knowing that there's a ton of other resources for students. And so you don't have to necessarily reinvent the wheel, but just making sure that they have access to these things because they're adults and they kind of have to guide the ship on their own. And so just knowing that there are other resources that you can lean on. Like all of the different national organizations all do residency fairs, so just making sure that your students know about them, know how to sign up for them. And a lot of times it's just different program directors who like get online on some type of online platform and have like 10-minute chats with students. Just making sure that they know that they can do that. I think EMRA has a really good match website where it's like a map and you can click a location and then it'll pop up with all of the different residencies in that area and then it'll take you to that specific website so that they can do more research. There are different scholarships for students wanting to go on away rotations, so just making sure that they, one, know that there's money out there for them to get in order to do these rotations and then how to access that information. How they navigate the VSAS website, and then focusing on who their other mentors are. At University of Michigan, there's different coaches for each student, so knowing that that is also a resource. Again, it's not the specifics of the information, but just knowing, again, like we're creating a story as to why you are a good candidate for emergency medicine, and so using your other people so it's not just on you as the clerkship director or clerkship team. And then specifically CORD, there's an advising students committee. So again, just more resources for the student. And if you go specifically to the CORD website, there are a bunch of different links that students can go to and click for whatever specific need that they have. So your student is now moving into the application cycle, and they're actually on their interviews. So advising looks like good interview prep. Some good things that they should be doing are having mock interviews. I think in the world of virtual interviews, also making sure that they have good lighting and like reliable internet access. That they're still dressing professionally, that they're remembering differences in time zones. And then just knowing that, you know, you get to 10, 12 interviews and all the programs start to sound the same. So from the onset, making sure that your students know that they should have a short list of like 2 or 3 non-negotiables that matter to them for how they're gonna train for residency, and making sure that they're going into each interview with those things in mind. So it could be that location, because your family is in a specific area, is really important. Keeping that at the front of your mind as you're going through the interview process. Or maybe you have a partner who needs to find a new job, making sure you keep that in mind. I think sometimes students get lost in the sauce of like, is parking paid for? Or like, this is how much meal allowance I get. And it's like, those could be very important to you, but making sure that your list is the same across all of your interviews, so that like at the end when you're creating your rank list, you have something to refer to that's a little bit bigger than kind of some of these like nitty-gritty nuanced details. And then the don'ts. I think it's important to like lay these out explicitly for the students, because you don't know what some people don't know. So just making sure that they have like some personality and some engagement on their interviews. It sucks to, you know, have a whole interview day and you're talking to so many different people and you get a dud and you're just like, wow, like, what do we got going on here? So just knowing that they like tell them specifically, like try and be as engaging as possible over Zoom. Making sure again that you're not late, even though it's virtual. You would be surprised as to like what happens. Like be mindful of like the time for like, bathroom breaks or for coffee breaks, and making sure that you're still punctual. Not to lose professionalism. I think it's different when you have to show up to a place in a suit and a tie, just like your demeanor and your countenance, just making sure that you're not losing that over Zoom. And then just making sure that they know specifically what are match disqualifiers, like questions that shouldn't be asked during the interview, or things that people shouldn't be asking you about as an interviewee. And then specifically around professionalism concerns, this is more so when the student is putting their application together, but also how they're going to address those concerns on the interview trail. So just being really upfront and clear with the student from the onset. Did you fail a course? Did you fail step? Are there any like legal actions on your application? Figuring out, is this something that you need to put in your personal statement? Is this something that's going to be clearly disclosed to the program, or is this something where they have to like dig through the website to figure out this is something on your application? And then prepping students, like if you have the bandwidth or the opportunity, like how are you going to approach these questions as they come up on your application? If there are any type of questions that you need to practice before you interview, making sure that you're addressing professionalism concerns is really important. So you get your students through their interview cycle, and they now need to pick a program. So making sure that they have kind of clear direction on, do they want to go to a 3-year or 4-year program, the pros and cons of each, and kind of what suits their needs the best. Geographic location, practice setting. And this is a question for the audience. What kind of advice are you giving students around the different CMG programs in the country? Because I feel like this is a big thing in EM over the years coming up. Yeah.
What's CMG?
These are the corporate medical groups. Yeah.
I think the really egregious situations have happened at some of the HCA sites, of which I think there are 30 or something now, and they've been closing down and stuff like that, as well as some of the newer, more tenuous programs, a couple in Ohio that closed down. So I think just telling them probably to try to avoid it unless they really need to be in a certain location or other extenuating circumstances.
Yeah. Any other approaches?
And so this is one of those where I actually am very upfront with students, like, I have my biases and this is my kind of bias with this, but if you have to be in Texas, you may need to apply to these programs, or Florida, another obviously big area that's got a lot of these programs, and just kind of, like you said, kind of making sure they have their eyes wide open when they go to them, to know, this institution or this group has had issues, or they've shut down, or other things, and make sure that they know what questions to ask, so that way they get down there, they get that information. I think, there are some corporate medical groups that I think do pretty good at educating. Actually, even at U of M, the Team Health actually staffs one of our sites for our residents. The residents love it there. They're great educators. I also know another site where Team Health is staffing at, where I've heard from students like, oh my God, I never want to go there. I never, that sort of thing. We get transfers from these sites too, and it's like, what are these residents learning? So there's just a lot of variability. So again, making sure that they know what questions to ask, what information, and like I said, for me, I'm trying to be upfront, like, okay, these are my biases, so they know that this is coming more from a personal experience or personal knowledge versus, this is just bad, just avoid them kind of thing.
That's supposed to say anticipate, not what that says right now. But kind of having an idea of where your student is going to land through the match cycle, so that we all have those above average students who they've got the scores, they've got the application together, they got all of the interviews that they need. Just remembering that the students, they should stay confident but also respect the process. I think we've all heard those devastating stories where it's like, this was a stellar candidate and we don't know what happened. So just making sure that they know, like, you still show up professionally, you still, hope for the best and know that the outcome is going to be good for you, but just avoid some of those overconfident pitfalls. Yeah.
Can I ask you a question about this, and I'll let you continue kind of talking, but how do you, similar to your question, how do you get a sense of this? Like, I've been a Clerkship director for a couple of years, and especially since, like, step one is now pass-fail, like, I have a hard time really, especially before their clerkship, saying, like, where they are on this kind of spectrum.
Yeah. I think for me personally, when I interview candidates, it's the candidate who's, like I said a little bit earlier, the candidate who's got the story. So it's like, it makes sense as to why they want to go into emergency medicine. They have a clear idea of what it is that they want to do and where it is that they're going. And I feel like that's kind of what sets the student who's just got the numbers apart from the student who's like, oh, this one is like who we want on the interview trail. So I think it's a lot more so about the preparation, rather than just like what the numbers are, because I do agree, like, step one really kind of levels the playing field. And so I'm not sure if you take or if you're a part of the residency interview process, but for me, I think that's also made it like very clear. It's understanding like what specifically our program is looking for and what they think is important, and also being able to relay that information to the students without like disclosing specifically what we're doing at Michigan and what we're looking for, but like the big ideas of like, we want students who are leaders, we want students who are innovators, we want students who have proven success in all of these different areas, and making sure that when students are crafting their application, that if you catch them early on in their preclinical years, that they have time to develop those things. And then if you're catching them towards the end, making sure that how do we look at your experiences and like tell this story of what we're looking for.
So the other thing is medical schools have access to a lot of data. So our medical school actually has, like, over the last, I think, 5 years of, where students went, what their scores were, what their, step scores are, what their grades were. So often you pull that, say, okay, historically our students with these grades and these step scores have gone to these type of programs. Also, one we probably should add when we think of revising this is, so the Texas STAR dashboard. I don't know how many people have heard of that. But it's actually, again, access to, it comes from a medical school, so I actually don't know if it's a pay-to-play or if it's free access. But again, it's the same sort of thing where you actually, in theory, I haven't played with it that much, but you can plug in a student with their scores and what grades they've got on rotation. And again, it kind of gives you an idea of
programs and number of programs and things like that. And that's one of the things, like when I meet with students, I try to, this comes over with what Matt Malone had talked about, I try to tell them that it's very individualized. I say, don't talk to your classmates, because I may tell you, you need to apply to 30 programs. I may tell you, you need to apply to 50 programs, because you're looking to go anywhere in the country and you're looking to go to the top competitive places. So I do kind of warn them that I'm going to give different advice to different students. Sharon's got something to add.
I mean, I'll also say that performance on their sub-I is going, and their global inform their slow is a big part of this, right? So we, this is a plug for my talk, which is next. So we all know that the slow is the most important part of a residency application, and it's run by residency program directors over the years, particularly a group slow. So I think that after someone rotates with you, for me personally, I feel like that's like a sign of where I can have a better idea and understanding as to how that student will fall kind of in relation to other students in that application cycle. So I think that that's a big part of when we're thinking about how we're advising students as they're getting ready to submit their applications. I think that's kind of a time that I advise them, and we'll also at that point also have an updated CD with any other extracurriculars, community service research that's on there, which I think is also a big part, because I can't remember who mentioned it, but there's just less discriminating or discerning information between students, which can sometimes, I think, in today's day and age, make this much more challenging.
What was the website that you mentioned?
The Texas Star.
Yeah, just Texas Star.
I do believe that is something your institution has to pay for. I know that my school actually just recently sent us each like links to it. So that we could have access to that. But I think it is something that is, you have to pay for.
Our sends it out now in the 4th year. It's like it's the 2nd year that we started using it at schools.
Cool. And then you have your average or kind of like middle of the road student. And so making sure that they're strategic in one, the programs that they applied to, but two, how they like rank those programs. Again, you want to have students, rank the programs where they're going to end up happiest, but making sure that they have a realistic view of like what the landscape looks like for them. And so once they've gone through the interview process, like how many programs did they interview at? Where were these programs? How does their needs as a student and like what they want and what their goals are match up to the list of programs that they actually have a shot at being ranked at? And just being really frank, this is not the time to kind of sugarcoat the evidence that you have, but just making it very clear for the student just so that they can kind of have a good idea of what's coming. And then your below average student, this is when you really want to make sure that you're leaning into the other mentors that the student has. So what is your Office of Student Affairs helping or doing with these students? Do they have other coaches? Do they have other mentors? What other resources do they have to kind of help them get through this process? And then before it's too late, is this something, did the student need to dual apply to another specialty? Like, did they need to consider family medicine or internal medicine? Just making sure that they have all of that information before you're submitting your rank list.
I'm a new Clerkship director. I just started this last year for our new program in East Valley Emergency Medicine here. And something I struggled with last year, I guess I'm still trying to learn, is how do you guide someone, because it was an AI, so they were coming to like see our program, but how do you guide someone away from emergency medicine if you feel like they're not going to be successful, or if they're way below or not where they need to be in their 4th year? Like, how do you have that conversation?
So I tell the students, kind of my introductory is I'm going to be as honest as possible. If I think you're not going to be a great match, I'm going to tell you that. I think if you're going to struggle, I'm going to tell you that. And I will tell you, I have had students who said thank you and didn't meet with me again until SOAP day because they decided they still wanted to do EM. So I wrote their slow and was honest in their slow and said, I'm going to write in there that you are unlikely to be on our rank list. So just being very upfront with them, and some get it and some just don't.
I think also, like, part of that conversation, like with how the rank, or like how the match has gone for emergency medicine over the last like 3 to 5 years, like the specialty as a whole is not as competitive, but some of the programs are still extraordinarily competitive. So it may be as much of like the conversation may be, you might not be competitive at University of Michigan, but there are a million other programs where that aren't filling their spots until so. But is that a program that they would actually want to be at, or they would have a good educational experience? So it may not necessarily be that they can't do it, but making sure that they understand what that experience is going to be like if they end up matching at a brand new program.
And I think also really being specific about what your advice to them is. It's not just on like vibes, like we just don't think you're a good fit. But is it that you had difficulty seeing undifferentiated patients and like the way you think and the way you process information isn't a good fit for the specialty? Is it that, but being really specific about what the issue is, because I think it's a hard thing to tell a student, like, this isn't gonna work for you without having some type of like concrete evidence as to why it's not going to work. And I think that's sometimes why you get the student who's just like, I'm gonna do it anyway. Or you get the student who's like, actually, I'm like hearing you, and these were the struggles that I had on my rotations. And I actually agree, like this isn't gonna work long term. So figuring out specifically what it is before you just kind of dive into that conversation of like, don't do this. And it could be the practice setting. It could be like you're at a very academic center, but maybe working at a community-based practice is something that fits your needs a little bit more. So just tailoring that advice to kind of that individual student. And then lastly, just not forgetting about your students post-match. I think your fourth years who have matched into emergency medicine are invaluable to your junior students, just because they all have different experiences. They rotated at different places. Their process through the match cycle, I think, is unique. And so making sure that you set up some time to have your fourth years talk to whether your EMIC students or your M1s or your M2s or 3s who are going into the cycle, making sure that they can kind of impart that knowledge. And then also not forgetting about them as they're moving into residency. So whether you have a boot camp or a residency prep course, just making sure that you kind of can do your best to like level the playing fields for these students as they're going into internship. So whether that's you're covering some high yield chief complaints that you really want an intern to be able to manage day one of residency, and then some of like the procedural components, making sure that they have like a basic understanding of ultrasound, making sure that they can do like basic lines and that they're not going into residency blind with these things. And then also thinking about like advanced communication, like how do you talk to consultants? How do you manage what do we call them? Like a rapid response. Just like kind of like those basic skills that you want an intern to not go into day one of residency blind on, if you've got the time or the bandwidth to do it. It's great, yeah.
My school is actually trying to set up this kind of boot camp.
Mm-hmm.
Do you have separate boot camps for different specialties or just general?
Yeah, at Michigan, we have one specifically for EM-bound students. And our course is 4 weeks long.
8 weeks.
8 weeks long. Yeah, so it's like a hefty time chunk, but I think, yeah, I think it can still be really effective in 2. So again, I think just kind of like the basics of what you want your intern to be able to fly with. So it's like if that's a couple of didactic sessions, whether that's like chest pain, belly pain, stroke, and then like lines, like putting in a central line, how do you intubate, what are your RSI meds, just kind of like those high yield topics, and then throw in a little bit of like how do you be successful in residency, like what are like your learning tools and strategies. I think you can build out a really effective course in 2 weeks versus ours, which is quite extensive at 8.
You said 2 weeks or 8 weeks?
At Michigan we have 8 weeks. I'm sorry, I don't know your name.
I'm Nathan. I have,
Nathan.
Right now they have a 1 week thing they're doing in 2 weeks and trying to expand it, and so thinking about doing specialty specific stuff in the second week. Trying to figure out how to build something.
Yeah, so I think you can kind of craft these to look like whatever you want them to look like within the constraints of your time. But I think if think of yourself as an attending and you're in the ER in July with an intern, like what are the things that you want them to know? And kind of build the course based off of that.
So how do you fit in 8 weeks? Do we have to be close to that?
Ours starts in February, so it's a little bit before match. Yeah, and so it's quite a long course. There's a bunch of didactic sessions. We're in the sim lab with them. We're doing, ours is like very extensive. And I only help with a little bit of it. I don't lead the course, so.
I'm just trying to visualize timelines.
Mm-hmm.
Is that like a Monday through Friday?
Mm-hmm. Yeah. Not usually 8 to 4. A lot of them are half days. Yeah.
So if we want to kind of keep moving around, if we have questions about the boot camps, we have another break coming up in a little bit. We can talk about it, and I can connect people with our boot camp director as well, and other resources.
Mm-hmm. And so I'm done. So just in summary, it can be really hard, but it's really rewarding. And I think if we think about who we want to kind of bring into this fold of emergency medicine, how we advise students can be really impactful and powerful. And just don't forget about using your outside resources so that it's not all on you as a clerkship director. And then thinking about advising as 4 years rather than just 1.
All right, thank you. I'm going to jump back to the slow talk, since someone had something better to do.
What's that?
I said, since you had something better to do earlier.
Thank you all for your flexibility.
Stay here, or are you going to wander? Because they told us to use the mic. If you
We have to use the mic. I'll stand here is fine. I can be a stander. Does anyone need to stretch? All right. Well, good morning, everyone. I'm really excited to be here to talk about the SLO, which is a topic that is very near and dear to my heart and to Joe's as well. And we are excited to talk about it. So what are we going to be addressing here? So what are our goals here? So we want to talk about what a standardized letter is, and the history of the emergency medicine standardized letter is something I always love to talk about. We'll talk about what the goals of the letter are, and I think we've touched on some of the challenges that we face as letter writers for these students. And then we'll talk about, again, some challenging scenarios. So by a show of hands, how many people like writing slows? How many people have written a slow before? Awesome. So it seems like everyone has written a letter. How many people enjoy this experience? Some people? Yeah, I think it's better than writing a narrative letter. So what'd someone say? Depends on the student, potentially. And how many of you are anxious about writing letters? Some people? Some letters are really hard to write, and I think we'll touch on the letters that are more challenging or harder for us to write. There are still some letters that give me a little bit of anxiety and pause as well, and I've been writing and reading letters for a while. So before standardized letters, in the time before we had these standardized letters, there were only narrative letters. And how many people think a narrative letter is helpful if you read residency applications? Rarely, right? So every so often you do get a narrative letter where you're like, oh my goodness, this told me so much about the student and I really learned a lot about them. But these are overwhelmingly positive letters. So when you read that letter, there's going to be a whole lot of superlatives, right? This is the best student I've ever worked with. This student was so strong clinically. This student is such a go-getter, and they've done the most research with me ever. For some reason, whenever you get those narrative letters, because the student selects who's writing those letters, you really get this overwhelmingly positive spin on a student, and it makes it very, very hard to discriminate between different students when you're reading these letters. So, and they also take a while to read. In emergency medicine, we sometimes don't have a very long attention span, right? It's something that we take pride in. So we want to maximize our efficiency when we're reading these letters and these applications. So in emergency medicine, we developed a standardized letter, and we were really trendsetters in the world of standardized letter developing. And in 1997 is when the SLOR, and originally this started out as a standardized letter of recommendation with the understanding that it would be positive for students and express positive viewpoints on them, and that was first used on residency applications. It was actually first developed in 1995. So a number of years ago. Some of you were maybe not even born then. Raise your hand if you weren't born when this letter was developed. Anyone? One person? So it's been around for a while now, and over the years, the letter changed from being the SLOR to being the SLO, and the wording changed to being a standardized letter of evaluation rather than being a standardized letter of recommendation. And we want to make sure that we are being honest and passing on data to our residency programs that is both honest and useful and helpful. We adapted this into an electronic system probably about 10 or 12 years ago, and that allows us to pull data from our system so we can really look at our letter performance. We can look at how different students are ranking over the years, how different residency programs or different medical schools are ranking people, and the program has just gotten more and more savvy, and we're really excited about the ability for us to really use that data and for us to use it to help us improve our letter and also to help medical students and faculty alike. And over the years, other specialties have jumped on board. So for those of you who are involved in your dean's office or kind of overarching advising of students in some way, you'll know that derm, internal medicine, ENT, ortho, OB, tons of specialties have really also started working on these letters and incorporating them into their residency applications. I would say some of the surgical subspecialties like ortho and ENT have been around for a few years. I think dermatology has been around for a while as well, and internal medicine and OB just started over the last 3 to 5 years. And one of the reasons that a lot of these specialties have started doing this is related to COPA, the Coalition of Physician Accountability, has recommended a push for standardized letters with the understanding that they will provide, again, residency programs with more discriminating and discerning information. Now, if you look back at the original paper that was written about the standardized letter, the goals that were stated by the kind of people who structured this letter were that the letter would be standardized. Obviously, that says it in the name. That the letter would be concise, that the letter would be discriminating and discriminating. And these things are really more important than ever because we know, and again, we've touched on some of these things this morning already, that there are less and less discriminating and discerning pieces of information that are coming otherwise from medical schools. Now, when we think about advising our students, there are 4 slots on your residency application for letters. And students always ask me, and I'm not sure if that was touched on in the prior lecture, I wasn't here for the whole thing, about what your letter should look like. So students are always saying like, well, I have 4 slots, what should this look like? Students will oftentimes, what I say to them is that they should have 2 ESLOs. So that is your letter that you'll get from your home institution and your away rotation. And that is oftentimes a group letter. So what that means is that it's authored by the clerkship director, the program director, sometimes the vice chair of education is on there, sometimes the department chair is on there. By show of hands, for those of you who write, are your letters group letters? Yes. So for most people, you'll be authoring a group letter with a variety of those people, and that's really like our gold standard letter. Students oftentimes will ask me like, well, if I go to a place, like, do I need to make sure they'll write me a letter? Do I need to talk to a certain person? And I usually will tell students that it's good to verify that you'll get a letter and an ESLO from that rotation, but it's almost the expectation. So when people come to rotate with us, I oftentimes, when they're doing an away rotation, I will sort of lay it out on the first day of orientation that we will be writing them a group ESLO letter unless they tell us they don't want one. which does happen occasionally if they rotate late or potentially they come. Sometimes students will come and maybe feel as if their performance was not as good as they would like, and they can opt to not get a letter from us. So what do the rest of the letters look like for students? And these are the different types of SLOs that exist. So you can have a non-residency based SLO. So if you are at a program that does not have a residency affiliated with it, is that anyone in this room? So a couple of hands went up. So you will be writing a non-residency based SLO, and the main difference between that letter and the eSLO is there is no question about where will the student fall on your rank list. That's really the only biggest difference that you'll see, because you won't be making a rank list, so you won't be having that question on your letter. The system in which you write that letter is also a little bit different. There's other SLOs that do exist out there. So there's a subspecialty SLO. I know someone had mentioned that they run a full EM rotation. They do a subspecialty rotation. I forget who it was in the room, maybe. So you potentially will be writing a subspecialty SLO, which can be authored by peds, tox, ultrasound, or any other kind of subspecialty within emergency medicine. That letter also very closely mirrors that formal eSLO. And then there's the OSLO, which is an off-service letter, which was developed during COVID when we were concerned that our students weren't going to be able to go and do an away rotation, and we wanted to have an additional standardized letter on them. So it is a letter that you can give that the student can give to one of their off-service rotation attendings. If they rotated in the ICU, if they rotated on surgery, someone who maybe knows their clinical performance reasonably well, and they can write them a letter within this format. We know that sometimes our students will ask for a narrative letter from those individuals, and historically, there was concern that individuals in other specialties would feel much more comfortable writing a narrative letter, and while that still is sometimes true, with the increasing use of standardized letters in other specialties like internal medicine and surgery, authors are increasingly comfortable writing these standardized letters and sometimes even prefer them. The other thing for everyone to be aware of, go ahead.
One common question I get, and I don't really know how to answer, is a student will have done a rotation and have a preceptor that they particularly liked or had a great experience with, and can they get a letter from that? The list of 4 you had didn't seem to incorporate that, unless I missed it.
Yeah. I'm curious what other people who have, advise students and tell them what letters to write do. I usually will discourage my students from getting an individual letter from a place that they rotated. And there's a handful of reasons for that. They can sometimes contradict each other, the letters that are written, and sometimes that's very confusing. And also, the goal of going and doing that away rotation is to get that kind of larger group letter. I do sometimes encourage students, if they have someone who they connected very well with, to make sure that the feedback from that individual is incorporated into their letter. And they can do that by talking with the director of their rotation, or potentially through the back end, having that individual make sure that their feedback isn't influenced or placed into the eSLO letter. Were you going to say anything, Joe?
No, I was just saying similar. So even at our institute, I think you mentioned others, but I'll have some students, I know so-and-so, and if they have an experience where they did research with them, that's fine. Yeah. You can have them write a letter about research, and they can add some stuff about working clinically with them. But yeah, I don't tell students not to get a individual letter from someone, at University of Michigan, because we write a group letter, and there does sometimes been contradiction in regards to rankings and other things. So that's how we do it, unless they've got some other reason to ask for another individual at my institution. I tell them not to.
Yeah, so, and if they're writing, let's say a student has done a lot of research with an individual within your department, I will have that person write a narrative letter. And I discourage my faculty from writing individual SLOs and tell them that if they have feedback for me on that student, that they should, outside of what they've put in their clinical evaluations, that they can tell me, and I will incorporate that feedback into my letter. But otherwise, I discourage faculty from writing other SLOs. I think it also kind of muddies the application a little bit. So just to sort of rewind to this based on your question, what should the letters look like on an application? So I'll usually say like 2 ESLOs, or potentially one of them being an ESLO and one of them being a non-residency based SLO, based on your clinical rotations and your clinical experiences. And then those other 2 letters can be filled in with either subspecialty letters, potentially with an OSLO, potentially with a research letter, or other narrative letters. It's important to note that you don't need to have 4 letters on your application. So 3 letters is perfectly fine for students. And students will sometimes also ask me, like, should I send certain letters to certain places and sort of cherry pick a little bit? That's something that I personally discourage, because I think you're ripe for getting yourself in a little bit of trouble. Same thing, you can write multiple personal statements and put those on your application. And I think that unless you are, I tell students, unless you are the most detail-oriented individual, to not do it, because inevitably you're going to send the wrong thing to the wrong program, and it's going to result in you not getting an interview offer there. Other thoughts? Yeah.
The one caveat to that, I dual trained in emergency medicine and pediatrics. There are only 4 of those programs, so I did have to send pediatric letters.
Yes.
And likewise, every year as clerkship director, I've advised EMIM bound and EMPs bound applicants. And so sometimes the pediatric side will, or the medicine side will appreciate a chair letter or a pediatric chair letter or something like that.
Yes, yes, absolutely. Those are special populations. And I know that Olivia had posted the CORD application guides that are online, and one of those is for dual applicants. And you're absolutely right. For dual applicants, that's different. Definitely for people potentially who are like couples matching or who are applying into different specialties, this can get very complicated in those specific situations. Thanks for bringing that up. So the next plug that I have, oh, go ahead. Yeah, absolutely.
Unless I blanked on this when you mentioned it, could you go back to the previous slide? I'm curious, in my perspective, perhaps I'm wrong in this, much of the purpose of subspecialty SLOs and OSLOs really came out of pandemic when people couldn't rotate. If I have somebody who has a great reputation with a surgeon and is going to get 2 ESLOs, I wouldn't tell them to bring the OSLO form to that surgeon. I would say let them write whatever they're comfortable with, because you have enough standard letters. I'm curious what others' perspective on that is, if it's not really a needed part of the complete application of 2 standard letters.
Yeah. Does anyone, I could tell you my thoughts, but I'll open to the forum. Does anyone here have other thoughts on what they do or how they advise people? I sometimes, like in today's day and age, oh, go ahead.
Well, I run our talks, I'm a toxicologist, so I run our talks course, and I mean, I think that my personal feeling is that the letters that I end up writing are really valuable because I spend so much time with each rotator in a way that, like, I mean, person who is writing our ESLO for our sub-I rotators, I mean, he might work 1 or 2 shifts.
Yeah.
But any student that he's writing the letter about, he's using it, he's using all this collected feedback and stuff that is of variable quality, whereas, like, I've literally spent 50% of that 4-week rotation with a student. So, I mean, I think, like, in that sense, like, I feel like the quality of feedback that I can provide about what is this person like day after day? Like, what is their role, like, in the group setting? How do they educate others? How do they help when a new person comes on the rotation? Like, what are the, I mean, I really do comment, like, on more than just, like, clinical acumen and sort of, like, their enthusiasm on shift. Like, it's a very different kind of picture, I feel like.
You do that as a subspecialty SLO.
Yeah, I think subspecialty SLOs have actually been around for a while. The OSLO is the one that came out of COVID. And I think that subspecialty SLOs can offer a nice perspective. I tell students who are asking someone off service for a letter, because the students like hear about this and like read about it online and they ask me what they should do. And I tell them that they can always present it to the individual, say like, oh, there's the standardized format. Would you prefer to use that? Either way is fine. Like I'll sometimes have them leave it up to the individual, but you're absolutely right that a lot of those individuals on other services just feel more comfortable writing a narrative letter about the individual, which I think is totally fine in today's day and age. We still have the OSLO format on the CORD site, because I do think that there is potential that some faculty may feel more comfortable writing that kind of letter, or may feel like it's easier to write that kind of letter. So we do still have it up there, but I agree that it's probably used with less frequency over the years, and that's what our data tells us. Yeah, excellent point. Excellent point. All right, so another piece of information for you all to know, and this is specific to this year in particular, but we have had a pre-SLO survey a couple of years ago as well, is that we know that this is a wonderful time to harness the power of all of our educators, right, from all the programs that write these eSLOs. And the goal is for us to kind of gather a nice national sample of individuals. So this year, we are looking at residents who have left programs and trying to gather data on a national level about why those residents left. And this is helpful information for our specialty as a whole, not necessarily specific to our medical school education or our job as clerkship directors, but will be helpful as we're advising students moving forward. When you go to fill out this survey, and again, we sent out an email about this, you will be getting, need to gather information for each resident that has left. And we sent out a piece of information on both the CORD as well as the CDEM listserv. By show of hand, how many of you are members of CDEM? If you're not a member of CDEM, you should absolutely join. I'm gonna put in a little plug there. I am outgoing president. Doug is? Joe, just kidding. Joe is immediate past president. Well, we're transitioning this year. Luan, who's in the back, has also been president of CDEM, and it is a wonderful, wonderful resource for all of you, and I encourage all of you to get involved. It's free with your SAEM membership. It's one of the academies within SAEM. So please, please, please join us. We have a business meeting tomorrow at 3:30, which will be a really nice opportunity for you to network and meet other people. All right, I'm getting... I'll stop talking about that. But it's really a lovely resource for clerkship directors, and I think that the more people we have there to kind of put in their perspective, the better that organization gets. Any questions about that survey? Just a little plug there for you to start gathering and thinking about that information. The next thing we're going to do, and so many of you are letter writers, so we can kind of go relatively quickly through this, is to look at the different parts of the letter. Of note, when you go into the site each year, it will save information from your prior years, which is very, very helpful. But if it is your first time writing, you may need to gather information as to the performances of students in prior years. So what their grades were, also what your rank list distribution looked like in the prior years. So just also going in and being prepared for that. We ask if it's a home versus an away rotation, how you know the student. Do you know them just as an advisor? Did you work clinically with them actually? And we want to know specifically who the person who is the point of contact for that letter is, because every so often residency programs read the letter and they're like, I'm not really sure exactly what to make of this, and they want to reach back out to you. So part A of this letter is based on the EPAs, which is something that more and more medical schools are using to evaluate students. And we want to know, based on these common things that we do in emergency medicine, how entrustable a student is. Much of this can, I think, oftentimes easily be obtained from your clinical evaluations. The other thing that I'll put a plug in for, and what some of this letter is based on, is the NCAT, which is a standardized nationally used letter for emergency medicine rotations. By a show of hands, who here uses the NCAT? So few people. I know some of us are really unable to use this based on our institutional guidelines, but if you're able to use it, it does actually make your slow writing a little bit easier if you're able to use this tool, because it does closely mirror the NCAT. Any questions, thoughts on that? What is the NCAT? So it is a I always, a national consensus test, clinical assessment tool in emergency medicine.
And a shift card. It's kind of
Yeah, so it's a daily clinical evaluation that you can use for students based on their performance on shift. That was developed 10 years ago, about. What's that? I was at the consensus conference. You were there too? Yes. Which took place, I think, at CORD, not at SAEM, if I'm not mistaken, where we helped, as a group of national educators, we developed that assessment tool, which is really valuable if you're able to use it at your institution and they don't make you use their homegrown or like their evaluation that is affiliated with your school. So I have to use the one affiliated with my school, so I'm not able to use the NCAT. We could do it in addition. So for those of you who use it though, we would love to hear your perspective on that. Part B are student characteristics, and this asks more about some of these soft skills that our students have. One thing that we added on to the letter is about kind of administrative skills. So for those of you who are always chasing students down about getting their required work completed, getting their patient logs done, we know that these are skills that sometimes follow individuals into residency and are very helpful for students to kind of have their executive function skills up to speed as they enter into residency. So that's, I think, a really helpful thing for us to evaluate for our students. And we look at communication skills here with both faculty, with families, with the team. Part C is your overall student evaluation, and this has two parts to it. So one part is how much guidance do you think that your student will need as they enter into residency? Minimal, standard, moderate, and most. This has actually been shown to be one of the more discerning things on our letters. And again, when this was placed into the SLO, we anticipated that most students would need standard guidance, and that's what our data shows us. About 50% of students are put into that standard guidance category. And then also associated in Part C is where you think the student will reside on your rank list. And then the most important part, maybe, I think, is the written comments. And the written comments are a place where you can both highlight things that the student are good at, and also anytime that you check the highest box or the lowest box on the letter, you are supposed to explain that within your narrative. It really also can help tell an entire and complete story of your applicant. Probably many of us have read letters where you're like, that narrative does not match the check boxes, right? And then you're left, again, kind of scratching your head, and those are the letters that frequently are a disservice potentially to our students and also leave residency programs scratching their head. And the last section here is institutional information, and this is when you're able to put information about your rotation, how you rank students, people who, unfortunately, the situation is for people who use the full scale on these letters, they sometimes feel as if they need to explain that within their institutional information. We put a third of students in each of these categories. We rank our students based on this data because it's less frequent that people will use sometimes that full scale, and they don't want that to be detrimental to their students. You can also say whether you're what kind of level trauma center you are, what your patient volume is, what your practice environment is, and that just allows for us to better understand the place where that student rotated. You may be wondering why that's helpful. Well, that's helpful because a student's ability to perform in like a level 1 trauma center in an urban setting may be very different than their ability to perform at a rural emergency department where there's less resources, right? It's different when you can send a consult to every single specialty and have them be there within a half hour versus a place where there's less resources. Now, what are some challenges that we face? So this is really a balancing act. Some people here may be in the dean's office, right? So we want to make sure that we're sending a recommendation for our student that will potentially allow them to match, right? We want our students to be successful and to match. But we also want to make sure that we're passing along accurate information of our students that have rotated with us to residency programs. And we also want to write a letter that is free of bias. And this is something that is particularly challenging. And although we are also cognizant of this in today's day and age, we also know that implicit bias is very, very common. And some words that we use can be biased against female rotators, against female students, can be biased against students of underrepresented minorities within medicine. So we want to think about terms that we use in our written comments and in our narrative letter. So there's communality terms, which are more frequently written about female applicants. And these are words about how helpful a student is, how excited they are to rotate, are they kind, are they compassionate, are they happy? For the women in the room, like, sometimes you get a comment like, should have smiled more, or, you know, should have been more excited to be on rotation, or maybe you get these in a positive way, versus agentic terms, more commonly used to describe male applicants. That they have skills, that they're strong, that they are leaders, dedicated, confident, active, intelligence. Within our residency program, this is actually something we're really focused on over the last few years, and it's really interesting to go back and look at your evaluations that you've written. We're specifically looking at evaluations for residents, but to really be thoughtful about the language that you use when you're writing about people. Are the characteristics that you are describing within your letter relevant to EM residency training, or are they not really relevant? We want to avoid invoking stereotypes, whether they're positive or they're negative for an individual. We really want to pay attention to a balance of using these agentic and communal terms, and there are a couple of tools online that you can actually plug your narrative into and see if you're well balanced. And you want to be mindful of whether descriptions of personality and interpersonal skills are relevant. And sometimes they are, right? So our job is very much based on, can we connect with other individuals? Do we understand how to work with a team and in the emergency department? But we want to make sure that we're doing that within the context of the job. What are other challenges that we face? So utilizing the full scale of ratings. How many people feel nervous if they rank someone as like a 1 or a 2 or pre-entrustable, that they feel like it's gonna really harm their student, right? Everyone, I think, feels that and wants to make sure, again, that you're putting your student in a good position to match and not being harmful to their application. Of note, this is not unique to the field of emergency medicine. We see this on all the standardized letters, and there's a lot of publications out there from other specialties that show that the letters are very left-shifted, very shifted towards a positive way. And we also want to make sure that our letter is consistent with rankings from our institution over the years, right? So how many people know, oh my goodness, they write a really hard letter. Like, there's places I won't send students to anymore because I know that the letter is going to be very err on the side of being a little bit more negative. But that is consistent over the years for that institution. So we want to be mindful of how over the years our institution is ranking people. And again, that there are places that you can describe that in your institutional information. We also know that it's really hard to divide students into thirds, which is why a lot of these changes on the letter came up, and why we went away from more comparative data to individuals' peers, and this rank list question, while it still exists. But that can be really hard to say, like, oh, this student is in the top 10%, but this one's in the top third, and putting people in the lower third is something that people are oftentimes hesitant to do. So that's another challenge that I think that we face. Now, what flows do you think will be harder to write? And I have a few here that I think are kind of hard to write, but just by comments, what are letters that people think are challenging?
Obviously, that challenging student where you don't want to submarine their chances of matching someplace because everybody's on a different level of that spectrum. Those can be the challenges.
Yeah.
Students that are kind of exactly in the middle. So you only have 300 words to try to say something about them, but they're just kind of in the middle of your book.
Yeah.
I've had students that are very polarized in how people felt about them, and those are pretty challenging as well.
Like a student who, like, some people were like, we love them, and some people were like, we don't love them.
Correct,
Yeah. Yeah, that is really, really hard. Do you have a comment in the back? No, okay. Were you gonna say something? No. I personally think letters that are very hard for me to write are the student who maybe has interpersonal issues or professionalism issues, I think are the hardest letters for me to write. And one of the reasons for that, and for those of you who train individuals, I think it's very easy, or not very easy, but it can be much easier to fix a clinical knowledge deficit, right? There's tons of resources for that. Like, you could study more, you can, we can provide you with additional testing materials, additional testing help, additional simulation sessions to help you come up to speed about how to improve your clinical performance. But I think giving students more clear guidance about how to improve interprofessional skills, I think is much harder for residency programs. So I think that they're more hesitant to kind of take a chance on an applicant that has those deficits or has those challenges, because it's a much harder thing to remediate. Other thoughts on this? How are we doing with time?
Oh, we're well over.
We're well over. Got it. Do we want to go through this exercise, or do we want to skip it?
No, I think this is, I mean, even earlier we had several questions on the slow, so I think we can spend time on it.
Perfect. Okay.
I'll just talk fast at the end.
We'll talk fast at the end. I love it. So here we have 3 different scenarios for students. So where you can go ahead and scan the QR code for a particular problem student or for a particular challenge, and look over their data. And potentially what we can do is we can have each table maybe choose one of these challenges to go through, and then you can talk amongst yourselves about what you think will be challenging about writing this letter, potentially write a fake narrative for the student if you want, and then we can kind of all come back together to discuss. So we can maybe take 5 or 10 minutes for people to choose one. I want people to choose different ones though. So what is everyone thinking that they're gonna do? I hear them, that they're scheming at this first table. I'll let you choose first. Number 2, all right, so table here is number 2. How about table in the back? What are you thinking?
Number 1.
Number 1, average student. So we'll have one person table doing doubles. What would you all like to do up here? You want to do number 3? All right, perfect. And the table in the back, you get to choose whatever you want. 3, all right, perfect. All right, so we'll go ahead and have everyone sort of report out. So we'll start with our table up front. So which one did you select again? The middle one, right? The below average student. So what are the challenges you think here, or what kinds of things would you write on your letter or check boxes?
Yeah, I mean, we were talking about how, this student, while they might be below average in the full context, has a lot of really good comments, especially about their interpersonal and their approach to learning and growth and stuff like that. So the important thing would be highlighting that and framing it in the context of they have some more to learn clinically, but that you feel that they're very much up to the task. And then further, like the, kind of framing that with the, the other parts of the slow letter, how much help will they need? And where will they be on your rank list? And if you see, it's like they need some help, plus they'll be in the middle of your rank list. Think, okay, they think they're fine, even though they're below average. So yeah, I think that would be a fair way to go, but it's balance.
Yeah, I love the idea of highlighting some positive things from the comments. I think is really important, and pulling out the things that the student did well on. I also think something that you brought up but you didn't necessarily say is that like different residency programs are going to be good at doing different things, right? And will feel more comfortable taking students. So some programs may feel really good or okay about taking a student that has some professionalism concerns. They have remediated past residents that have had those kinds of concerns. And some places may be like, ooh, a lot of clinical knowledge deficit. Like, I've dealt with that before, and I've had a lot of challenges with that, and I don't want to deal with that. So I think it's important to highlight what the student is good at accurately and what the student is challenged with, so the residency program can, again, go in with like eyes wide open and understand that kind of person that they're going to be getting for residency. How about you, table in the back?
So we had average student scenario 1, and with the material on the Google Doc, I think we talked a lot about finding ways to highlight, I think in this setting, particularly teachability. The picture painted is somebody who has sort of reasonable medical knowledge, reasonable numbers, but what shown about them was their engagement and their teachability, and that's something that many of us would happily take a student who's a little
Yeah.
bit that we know is going to be driven under our wing and go further.
Yeah, absolutely. I think the average student is sometimes the hardest one to kind of highlight the, good things potentially about them, because everything is sort of somewhere in the middle. So I think that that's really nice to highlight, like that someone's teachable, because I think from someone who is involved in residency education, all we really want is people who are excited and interested to learn. So to highlight the teachability aspect, I think is really important. Other thoughts on writing a letter for an average student? All right, and then for the professionalism concern, what did you all think for that?
We wanted to highlight the, we all felt it's important to be very honest in that letter about that there was some professionalism concerns identified. So it's easy to highlight the fact that it's a very engaged student, clinically and technically excellent, well above average EM student. However, there was a specific point of professionalism identified regarding contact with patients and interactions with patients regarding choices to come to the emergency department, and that student seemed reluctant to accept or had some difficulty accepting feedback in that situation.
Yeah.
And although it was only identified in this one particular area, we all felt it should be mentioned.
Yeah, definitely. It's something that you have to make sure, I think, that you address in the letter. I think it's important to note when we read those letters that our jobs are really complicated, right? And I think that we all do better with feedback, oh, you did bad on a test, or you don't understand this concept, versus you did something that was kind of rude or mean or inappropriate. I think that feedback is sometimes hard for individuals to take, and I think it's important to remember that in the learning context, that's probably also very challenging, and to kind of help frame it with the student is really, really helpful, and to explain to students about like perception and how important that is. But I think definitely being honest about this as you pass the information on is important.
My mind, if I'm reading that, I'm going to worst case
Mm-hmm.
scenario. So when I'm actually reading this, I'm not too worried about this student, I don't think. But I think if you write it as there were some professionalism issues, I'm going to go.
Yeah, so to be as specific as possible, I think can be very helpful here. Yeah.
I get questions. I have questions about this a lot. So somebody who I write slows, but I don't read them because we're not affiliated with the residency program. So I've had phone calls from residency programs regarding my slows because I follow the directions that says be honest and exactly. And I get repeated ones that say, we just noticed you mentioned this in situations exactly like this. And can you give us a little bit more information about that? And they invariably say something like, because we get so many sugar-coated slows that we just felt like we should call you and ask. So my question is, am I doing my students a disservice by following the directions and being honest if so many people are not?
Yeah, that's a really big question. I think we're running a little late. And I think it is a really hard question to answer. I think that we are doing our training programs a disservice if we're not being honest, but I think it's very hard to kind of find that push-pull balance between giving that honest picture and potentially being harmful to your students' chance of matching. And I think that it varies, again, depending upon how competitive of an emergency medicine application season we're immersed in. But I think that's kind of the age-old question of these letters, and definitely a bit of a moral dilemma.
But I also want, you know, and I recognize it takes years to develop a reputation, but I also don't want to be the one to say, oh, you know, Hodges or WSU wrote this letter,
Yeah.
glowing letter, and this is the worst resident we've had, and the highest maintenance resident we've had.
Yeah.
Well, that's what I was going to add, because we actually had a student from a well-known program that, if you, afterwards, after that student actually left our program, or resident left our program at that point, when you kind of read through between the lines, maybe there was something there, and I'll just say we haven't matched someone from that program since. Because in the back of our mind was, well, we had that one person, this letter kind of sounds like that. So, like I said, it's that balance, because you also don't want to put future students where they have that bad applicant.
I think the most important thing you can do, and then we'll finish up because, again, we're running a little behind, is being consistent, right? Because then people will know what to expect from you and know that an honest letter from you is an honest letter from you, and oh, we called him and he explained to us what the situation is, and versus being inconsistent about how you write your letters. And I think being consistent and is the most important thing. But it's definitely hard. All right, excellent. Thank you all so much for your time and for your engagement, and open for other questions kind of after the fact.
All right, we're going to talk about a much more exciting topic, or maybe not, LCME. So if Luan, if you want to head on up.
All right, just show of hands again. Who has a required emergency medicine clerkship? All right, so this is going to probably impact you all the most. And those of you who have selectives, like it's part of ICU or other things that are required. And then who has purely electives? All right, so I'm going to go through this pretty quickly. I'm happy to talk to people at the end. I will tell you, I'll try not to let it come out too much, some PTSD. Between switching institutions, I have been through now 2 site visits in the last 3-ish years, and so there's some scars along the way. But I think really probably one of the most helpful things that you can do is recognize early on that accreditation standards are really changing, and that there has been, there is a hidden curriculum to it. They will tell you that there is not a hidden curriculum to it, but some of the things when you look at the standards, it looks like it's very obvious what they're asking for, and there's frequently some historical aspects of that you need to understand. And I think as emergency medicine clerkship directors, frequently we're on the leading edge of change. We're the early adopters in groups. And so that is really appreciated when people are trying to, line up things according to the standards, making sure that things are compliant with the LCME, and really sort of being an early adopter in that, even if you realize that it's going to change your practice in some way. People are not trying to do that to you to torture you. They're trying to make sure that you remain in an accredited medical school. And so when we look at the LCME, what are the purpose of this? This is really, they have a number of standards that they really are built in self-assessment. This is peer review. They're going to be people like you, deans from other schools, student affairs folks, medical education folks, who are going to come and visit your school, and they are going to look at thousands of pages of documentation that are submitted to them to really make an assessment. Are you meeting the accreditation standards? And the goal of this really is to foster institutional quality improvement, and so that you can improve upon the program. Unfortunately, the way it's built is an 8-year accreditation cycle typically, and so what typically happens is people begin preparing somewhere about 2 to 4 years in advance. By the time the LCME comes and goes, people are exhausted, no one wants to hear about it again for the next 2 to 4 years, and then you find yourself behind as opposed to really continuously improving with that. There are standards that, and how many people have been through an LCME accreditation visit? All right, so for those of you, these are standards that cover everything from the curricular content, which we really think about, to the relaxation space, to faculty promotion guidelines, to financial aid, and from the building to the processes, everything in between. And so the goal of really thinking about this is there's a self-study component. And this is really an opportunity for schools to look at themselves, to think about what needs to be improved. It is highly dependent on student opinion. There's actually been some work over the past year where they are changing the independent student analysis to really change some of the questions, because the way that some of these questions have been interpreted, particularly around things like relaxation space in the clinical sites, has come up. A number of schools have been cited on that in recent years. But the goal is to really take a look at this firmly beforehand, to really determine what are your strategic areas and how can you really drive that forward. So for the most part, they really are going to be looking at things overall. These are policies that govern everything. However, there are some challenges that come up, and specifically if the clerkship or a course has struggled over time, and those show up on the graduation questionnaire, those things are things that you can get cited for relatively individually. When we look at frequently cited standards, they are particularly around these things, although in the past year we were talking about diversity with the SCOTUS decision. Very recently, in the past couple of months, the LCME actually came out and said for at least this year, given the current climate, that no one would be cited on element 3.3 because of the significant challenges both federally and with state laws and how to interpret that. But a lot of these things around, we've already discussed the learning environment and professionalism, student mistreatment, as well as curricular management, design and review, preparation of residents, and assessment systems come up. So people have very different reactions to this, everything from I don't want to hear anything about it to ignoring it. And so really thinking about how you contribute. So they talk about an assessment system and direct observation. They ask questions, particularly, how many people have actually seen the graduation questionnaire? All right, have you seen your data for your institution? Okay, so if you're not seeing it, you should really ask to see it. Unfortunately, there are very limited questions on emergency medicine compared to a lot of the other specialties, but still, there's still an opportunity, I think, for us as EM folks to have an additive role. And also when they're asking students questions like, were you directly observed doing a history and physical? The things that the students have, there's recall bias built into this. They're thinking back to things that are 2 years previously, but if you're really making sure that students are being directly observed on their emergency medicine clerkship, then that's going to actually help reinforce that not only is that important in the third year, but it's important in the fourth year as well. But think about other ways that we can make sure that students are directly observed. Things like OSCEs and simulations, making sure that that those things that you're calling it out to students, because frequently they don't understand that it, you know, I've had students frequently think, well, I'm going to be observed from the entirety of an encounter, and you really don't have to be. You can be observed just for the relevant portions. So for one patient, that might be actually watching a pelvic exam. For somebody else, it's getting the HPI, and really articulating, making sure that you're signposting those so that the students recognize that they're being directly observed and not just sort of slipping into a counter, or you don't trust them to do it, so you're slipping in the back of the room, but really sort of articulating and giving them feedback associated with it. 6.2 and 8.6 are linked together, and this has required clinical experiences and monitoring. Students frequently hate this. I won't lie. It's not the most enjoyable thing either to make sure that students have checked off on these things. It is important, though, institutionally, that these are developed as a group, that your curriculum council is approving these, and that you, when the LCME comes, you can offer some discussion as to why things were selected. So why require certain things in the emergency medicine clerkship, or if you don't have any required clinical experiences in your required EM clerkship. Why is that? Are these only divided among third-year rotations? But they're going to expect that these are monitored both at the curriculum at your clerkship level as well as at the at a higher curricular level, whether that's your Office of Medical Education. So students, what you can't have is students who are getting through the clerkship and not achieving these, or you don't have effective processes, and that can result in a citation related to that. You also have to define your types of patients and clinical experiences, where that you expect them to be seen, and their expected level of student responsibility with that. So that really means that you need to articulate very clearly with the students when they're coming in for orientation as to what that looks like, and then keeping track of these. The LCME doesn't actually say how many clinical experiences that they have to do. We've typically only required one and encouraged students to log more. I think students see it as a burden to log things, particularly when they don't see the outcome. So if you really are able, if you're requiring students to use more than one, this can actually be pretty helpful in thinking about comparability of your sites. If you're sending students out to multiple sites, are students struggling in one site seeing certain types of patients compared to other sites? And so think about how you use that data and then how you feed that back to the students to make sure that they understand. I've already sort of touched on the fact of LCME, there's some hidden curriculum in there sometimes. There's a lot of guess what they're thinking. This is the one thing that they're very clear about. Grades have to be back in 6 weeks, no exceptions. You actually have to provide sort of the minimum and maximum numbers of days and average numbers of days. And if there are any exceptions to this in the couple of years, and so if you have a required clerkship, there's greater attention to that and making sure that you don't have any outlying grades. So that means that if for some reason, let's say a student it becomes ill or doesn't complete it, they need to have an incomplete documented so that it sort of essentially stops the clock for you. Also, one of the other standards is formative assessment and feedback. For the clerkships, this really is mid-clerkship feedback. They are going to ask students about not only whether they received it, which is what they ask on the graduation questionnaire, but on the independent student analysis, they ask about the amount and the quality of it. And so really thinking about how students can use that feedback early enough in the rotation to make a change in behaviors if they're not meeting expectations. And really it's only fair. I mean, I think all of us want feedback. We all want to know how to improve. It's not just whether students need to improve, but even our great students want to be better. So thinking about that as a gift to them and thinking about how to document that. So sometimes we run into a situation where clerkship directors are like, I can pull out the sheets and show you 100% of students have been given mid-clerkship feedback. And why does it say that only 93% of students actually recognize that they received that? We actually incorporated a student self-assessment as part of that because one of the challenges, one of the other standards is related to fairness and grading and assessment practices. And so we incorporated a self-assessment piece of that to really help compare okay, this is how you perceive that you're doing things, and here's how others perceive and the faculty or the residents perceive that you're doing. And if there's a mismatch in there, it really creates an opportunity for discussion. So like that student who had the professionalism concerns where it clearly had happened on multiple different shifts for the professionalism slow, it really is ideal to have those discussions early with the students and with the learners before they are making it to the final form or our final grade or making it onto the slow, because if we have those discussions early, then people are able to change their behaviors and really understand that sometimes there's a difference in perception. But making sure that these cards are filled out. I'm going to skip over the shift cards because we've already talked about assessment and grading, with the caveat of making sure it is a requirement that students receive narrative feedback as well, and that's a different standard. So students are going to be asked about fairness of assessment practices, but really the narrative feedback is our opportunity, even on the shift card, to clarify what their behaviors are, and that helps everyone understand what those expectations are. One of the things that has changed pretty significantly, and I think increasing expectations around, is curricular management. So I think lots of times, at least when I was the clerkship director, I was like, wow, this is my clerkship. You can kind of do what you want. You can teach what's exciting. Even better yet, CDEM put out a curriculum that gives recommended topics. However, with that caveat being said, the LCME does not necessarily appreciate that. So I was brand new clerkship director. They, of course, are asking us, well, how did you figure out what your objectives are? And I'm like, well, I took them from CDEM. It's a national resource. Why wouldn't you use these? There's really a tremendous amount of emphasis on tying into your own institutional, your educational program objectives, and so you need to figure out how this ties into your institution while using in the background the fact that there's a lot of national recommendations out there as to what should be taught, but really think about how that ties into your picture, what's taught in the remainder of your curriculum. All of this has to go into curriculum mapping, so you're going to need to be able to provide examples of, or your institution at least is going to be needed to provide examples of how they have changed curriculum based on curriculum mapping. And they, my most recent visit, they wanted to know how we changed assessment. So fortunately, we were well prepared on that. But any of your clerkship level objectives, these typically have to be, if you're making changes to your clerkship objectives, they are going to have to be approved by your curriculum council. And so it's really important to know what are your policies and what sort of governs that, because at least for me as a brand new clerkship director, I had no idea what really needed to be changed or not. And so those are important things to be able to clarify. Again, things with the review and the revisions of the curriculum, not only, so there are things that you're going to want to change that are really important for you, but sometimes they significantly impact other clerkships. Maybe someone else isn't teaching a lecture on airway because they're expecting you to do it in your clerkship. And so while sometimes we think about just our sort of piece of the puzzle, it really has the significant potential to impact others. Clerkship objectives and having written objectives have actually been a top citation over the years. So these have to actually be written in competency-based verbiage, and they have to have measurable outcomes with them. So someone at your institution is actually going to have to pick 3 of your larger objectives and be able to map these downward and be able to give outcomes data related to each of them. So making sure that these tie in effectively will be important. Teaching your teachers is going to be important. And this is one that has changed pretty significantly. Ties not only into 9.1 and 6.1, but you have to actually document that you have distributed your clerkship learning objectives to all of the residents and faculty who teach for you. Not only that, but they have to, people need training. There is a new requirement with 1.4 with affiliation agreements that now they are requiring affiliation agreements with outpatient sites and with individual preceptors. So if you are a site that has sites that are not associated or part of your healthcare system, you really need to dig into that with your medical education dean or your student affairs dean and whoever handles that to make sure that those affiliations are complete. Also, if you have residents who are from other systems that are not part of your main system, you have to be able to document that those residents receive residents as teachers training as well. And this has changed dramatically over the past decade, where at one point in time they're just asking sort of, what do you do? And now they're like, provide the documentation and all the policies that this impacts not only internal but external sites as well. Additionally, if you have multiple sites, you have to think about comparability across those sites and thinking about how do you know that people who go to site A have the same experience as B. So you can look at things like your required clinical experiences. If you give a shelf exam or the SAEM test, you can look at scores between those sites, the number of patients seen, and you can actually look at their evaluations. But if you have a required clerkship, they're going to expect that you're looking at the comparability and can prove that students are having a similar educational experience, even if there are nuanced differences between them. I'm going to breeze over these quickly, but interprofessional education is something we certainly have a huge opportunity for in the emergency department. So make sure that not only are your evaluations up to date, if you're not familiar and have not been through an LCME visit, all of the information is included on their website. Instead of just pulling the very superficial, like there's a 25 or 35 page document that gives the high level standards, I would suggest that you pull the data collection instrument, which has all of the questions. And then you begin to see the types of data that they're going to be expecting of you. Also knowing if you have had prior citations before. So this is one of the ways in which, again, I think emergency medicine can really help sort of lead some of these discussions, at least help. I think we're used to changing a lot in emergency medicine, and so thinking about what are the changes, how can you implement that, how can you support them. Recognizing, again, the affiliation agreements and faculty appointments are critical, and it is likely that they could ask, well, let's see a copy of those when they come, and so making sure that those things are in place. When our most recent visit, they actually asked us to pull data from our residents as teachers training program for all of the external residents who are involved in that. And so really keeping, making sure that you're documenting all of the processes that you have put in place is critically important. And I am happy to answer any questions, and if anyone is looking forward to an LCME visit, I'm happy to have much further discussion with you.
Now, with this last set of slides, I'll admit they're not my slides, and I just found out less than 24 hours ago that I was giving this part of the talk because the person who was going to give it had a family emergency. So since we are behind, unfortunately, I will be doing what you're not supposed to do and doing a lot of reading from the slides. But we're going to talk a little bit about assessment for emergency medicine. So I actually do have a photo in here, or a scanned copy of here, of what like the NCAT looks like and what we use at Michigan. I do want to credit these. So Jules Young is who gave this talk last year. So these are her stolen slides. So kind of why do we assess students? So obviously faculty develop professional growth, giving them feedback on what they need to work on either professionally or academically. Want to try to increase that drive for learning, identify students who need help. And that's one of those areas where I actually tell students, because again, when there's a mention here about mid-rotation, I think Luan mentioned it too. When I'm meeting with the student, I don't always know areas that they need to work on. And that's one area that we just generally are not great at doing. I can tell you we're not great at doing it for our fellows, not great at doing it for our residents, and not great at doing it for students. So really trying to help identify what areas the students need to work on. Certified competence. So again, a lot of med schools are going to more of these competency-based. We have our competencies. So again, how are we actually measuring, how are we actually certifying that these students are competent? And then, the assigned gradings and rankings, which, can cause a lot of angst. I know it does for me. When you're saying you're a competency-based program, but yet you're trying to, give grades to students and individuals. So what is assessment? So you're measuring of competency. So there's formative, which is feedback for improvement of performance, and the summative. So again, that's the stuff that goes into your scores, your grades, kind of, for your pass-fail program, but does that determination. And, again, kind of struggle when you're trying to provide students that formative feedback on, hey, here's where you need to work on, but then again, then it's incorporated into summative. So again, some programs I think actually separate that out. I know for us at University of Michigan, some of the longer clerkships, so like the 8-week clerkships, actually talk about, hey, your first week, it's all formative. We just want to provide you feedback for you to work on. In the last, 6 or 7 weeks, that's actually what counts for your grade. Obviously, for emergency medicine, like for me, students do 14 shifts. So, saying you don't work a week, or, well, that first week doesn't count, that's a third of the rotation almost, depending on what their schedule looks like. And then evaluation, so measurement of the value of the programs or the curricula. So competency, so the extent to which the construct can be mastered, including knowledge, skills, and attitudes, and again, must be objectively defined and measured. So again, kind of going back to what Luan talked about with, what are your objectives for the med school, and then what are your objectives in, your rotation, and how they relate to each other. So some of the differences in definitions, so competencies, essentially domain of ability for health professional, versus milestones, which are a level of performance for a given competency, and then EPA is an observable unit of professional practice. So again, assessments and goals. So again, reliability, so making an assessment precise and reproducible, versus the validity, which is ensuring that you're actually accurately assessing what you want to assess. So again, it kind of shows that this kind of on the left-hand side, you kind of have that there's dots everywhere. So again, not reliable, not valid. Where again, you could have a tool that's very valid. Everybody's giving you the same answer, but is it the actual answer that you're looking for? Or versus a valid one, which is, again, you're hitting that target that you want to get, and everybody's consistent with that. I can tell you, mine is kind of a mix between the first and the last one. Where they if you average them all, they're probably somewhere around valid. But then if you actually scatter plot them, they're like all over. So again, reliability is not necessary, is necessary but not sufficient for validity. There's no such thing as a valid but not reliable assessment. And then reliability is reasonably binary. You have it or you don't. And then again, validity is on that continuum. So here are some of the common assessments in clerkships. So Gestalt, which is again, I think this student is fine. So not likely to be reliable and not likely to be valid. Direct observation, again, depends on your tool. So it can be plus minus. If you got a yes/no tool, then it's actually probably not too bad because you're obviously clicking yes or no. Versus one with a little bit more, probably actually bringing a little more Gestalt. The NBME or the SAEM exam, thought to be reliable and valid. Internal exams, again, depending on how much you're able to validate those studies, are most often less reliable and less valid. Simulation-based exams, so OSCEs, so again, often reliable, but again, validity, same sort of thing. It's going to depend on how you're measuring those and your experience along with that. Computer-based simulation, again, very similar to the simulation-based ones, and then documentation review. Again, depends on a lot of time on what that tool is that you're using. So again, what are some of the things we can do that actually enhance reliability and validity? So again, using assessment tools that are available, which again, like NCAT or some of these that are nationally validated. Rater training and collaboration, or calibration, I mean. So on a yearly basis, I'm in front of my faculty, I'm in front of my residents talking about our assessment tool. Now we have a couple of experiences with interprofessional education, we work with nurses. So we actually have a tool that we send to them that they can comment on. It's kind of like the, keep doing, modify, start doing, but I actually don't have like any sort of score on there. And because I can't go to, because we actually have 4 different sites. So I can't go to those 4 different sites and teach, over 1,000 nurses, I think, between the sites, how to use that tool. So how do we get around that? We actually don't have them. We look at their comments when we do grades, but we don't actually look at, those kind of things. So more direct observation, again, less Gestalt. Expert review of the internal assessment content, and then doing the math. So again, one of the things we look at is shift cards. Things are probably the most common way that we assess our students. So some of the pros are quick, easy, again, familiar, potentially formative, have done well. Some of the cons, generally measure only 2 factors, again, skill or duty. Global score, predictive of individual domains, meaning, we'll all have seen those evaluations where, it's kind of the circle down the middle. So again, it's really just, and if you get down to a lot of those, you really can go away from those. So again, like we have on ours knowledge, and we have patient care, and we have communication skills, but we actually only have one question where they kind of do that ranking that we do a 1 through 9, which is stupid, but anyways, do that 1 through 9. We only have that question because if you look at it, they all, when we had 5 domains, 5 numbers, they all end up being the same. So we actually only have 1 question on ours. Often measures rater tendency rather than learner performance. Requires significant rater training to work as intended. And again, there is a huge potential for bias. So clinical assessments, so the anchor to rating scale is most common. Often institutionally mandated. So again, as brought up earlier, can you use the NCAT that there's data nationwide, or again, do you have to use your institutional one? Widely variable across institutions. So again, it would be it would make grading slows a lot easier if I think there's 212 clerkships. If there was, or 212 residencies. If everybody, all the programs, all the clerkships were related to those residencies, even if they all use the same tool, then writing this slow would be a lot easier, because again, you can directly bring that data, it's easier to compare, but that's not the case. And then like I said, some of the expert consensus would be the NCAT. So again, I know it's blurry, but you can kind of see. So one of the things they looked at is they actually use pre-entrustable, mostly entrustable, fully entrustable, and then outstanding. So looked at focused history and physical, ability to generate a differential, ability to formulate a plan, observation, mentoring, and follow-up, emergency recognition and management, patient and team-centered communication, and then some professional attributes. So again, there is data kind of looking across institutions, because every couple of years they kind of get data from those institutions. But the one thing you can easily see though on this, I mean, you're going to see a lot of those one-liners. People may say that they're all mostly entrustable or fully entrustable. I have some faculty who will just never do the higher score because they say, well, no student is ever going to reach this. So again, so then do you even have that on there, for some of these things? And then, so what we're actually in the process right now of changing our grading format at Michigan, partly because the LCME, with our LCME review, students were very unhappy with our grading, because, and part of it was because, like I mentioned, students would get a score, students would comments, and then I'd meet with them and I couldn't always tell them, well, your comment says this and that's why you got the score. Sometimes it's, well, maybe this is what they were trying to say, maybe this is what it means, and they're really trying to get it, from what I was told, is they want it so that students can actually get their evaluations back and kind of calculate their own grade, which I think there's issues in it of itself, because it kind of devalues comments and things like that, but again, that's a whole different thing. But this is actually what we're looking at doing. So again, your history, your physical, clinical reason, there's other questions too, but I just kind of did a quick screen grab. And again, requires major assistance, requires some assistance, gathers history independently and completely. So again, you're gonna have people, like I said, I have my associate chair for education has said, well, I'm never gonna say someone gathers history independently. So I just know that they're never gonna do that. Because they said, well, some of our residents can't even do this yet. So why am I gonna say a student can do that? But then again, what's, how are you going to have someone, okay, what's major versus some? So again, that's some of the education you need to do with it. And again, you can kind of see how those similar themes where differential and formulation are prioritized, problem often brief and missing key information, and then formulates problems appropriately, then formulates problems appropriately and completely, independently. So again, there's just some subtle differences that, again, it's that training you need to do. So that's my next step, is actually standard setting for this tool. And what I'm running into is the way we do it, required rotations are during kind of like their second year, we're in their third/fourth year. So I have some students who will be graduating in 2 months, and some students that don't graduate for 18 months. So again, how do you compare those students and do the grading for those students? My med school more or less has said, we don't know what to do with you guys, so you guys just do it something, let us know how you do it, and we'll let you know what we think of it. So we did standard setting for the other rotations across all 8 required clerkships. We're going to do this just in emergency medicine, because like I said, other people aren't sure what to kind of make of us. So if you do develop your own tool, things not to do, less is more, so minimize the number of domains and levels. Provide clear behavioral anchors. So like I said, some versus always, again, being clear, so if I'm reading that, I know what the difference is. Use the right scale for the job. Don't be rate binary, construct 5-point scale. Avoid the extreme descriptors. You may want to use, raters use the whole scale. So our initial evaluation, like I said, it was a 1 to 9 point scale. The 9-point scale was written was on an attending. So why have that on a medical student one? And then they changed it and said, oh, it's like a senior resident. Again, why are you having that on that school one? Then eventually came down to, well, it's kind of like an intern. I'm like, okay, I can kind of see how some of our students, might be able to get close to that. But again, use a scale. If you're going to have a 9-point scale, you want students to use that 9-point scale or a 5-point scale or whatever your scale is going to be. So how to do it better, again, rater training. So the goal is that shared mental model. So in October, when I have my faculty meeting, where I'm going to talk about the new grading form, that's what we've kind of talked about doing, is actually creating scenarios like with what Sharon showed, and say, okay, here's this student, where would you rate them? And when there's differences, okay, why did you put this one at a sometimes and you put it as an always, and try to create that, like I said, that the shared mental model of what that student is. So when I read this evaluation, I'm picturing that same student as when you're reading that evaluation or you're reading that evaluation. Orient raters to the tool. Again, set expectations clearly, encourage honesty. Again, I've had people not fill out an evaluation because, you know what, that student looked lost, but I didn't want to screw up their grade, so I didn't want to fill out an evaluation. It's another data point. What I tell our faculty, and I've looked at the data, and it's true, I'm not just saying this, one evaluation doesn't sink a student. On average, I get 10 to 11 evaluations back per student. So yeah, that one evaluation is a tenth of their grade. But again, that's not going to sink them from an honors to a pass. Depending on where they're at, maybe moves a little closer down into the high pass versus honors range. But that one evaluation doesn't sink them. Like I said, it's just data points. So identify and correct hawks versus doves. Again, that goes along with training. For a while, I was actually sending out the average and standard deviation for each of our sites along with the individual faculty. So like I'd get a report saying my average score is a 5, my standard deviation is a 1, my site's average is 5, and standard deviation 1. Oh great, I'm where I'm supposed to be. Then I've also had some faculty who, when I did that, said, wow, I didn't realize how easy of a grader I was. Or, hey, I didn't realize how hard of a grader I was. So you can try doing that. I think the data says that you do affect change for maybe 3 months, 6 months, and then people kind of revert back to what they were before. So again, it's a continuous process. We can try doing that. What we actually end up doing is we get a Z-score. So again, it's kind of where their variation is based off of their mean, and we use that in our grading. So I know this faculty member always gives a 4, so if he gives a 5, because I get a positive Z-score, then I take that into account when we review our grades. Versus this person's, gave them a 7, oh, but they actually have a negative Z-score. They always, they usually give 8s. So again, we actually did it with, actually using a formula, which is beyond my understanding. It actually didn't make much difference. So now we just kind of use it more as an eyeball test. Hey, everybody, on average, you're probably right in the middle, versus on average, you're all positive Z-scores. It might be more likely to bump you up to like an honors or something like that when we do our grading. And then monitor for bias as well. So some of the pitfalls, getting that halo effect. I have not looked at it. But I can just gestalt, which again I said is not valid. The good students receive more evaluations back, and they're going to be higher. And sometimes by a good student, sometimes it's just that really friendly, outgoing student. Versus, like I said, the one who's a little more reserved, who may actually be a great student, but being a little more reserved, that makes you knock them down a little bit. So again, that halo versus horns effect. Raters' personal philosophies, fear of harming students with the truth, and again, our own personal biases. All right, so bias in assessment. So white students are 2 to 6 times more likely to receive honors. Race and gender stereotyping and narrative assessments. White men's more likely to have standout terms. Women, again, this is kind of brought up, more the empathic terms, caring, compassionate, kind. Blacks more likely to have grindstone terms, so hardworking, diligent, or to be described as minimum competent. So one of the ways that we try to get around some of this, obviously making people aware of it. We do bias training, but we actually have 6 to 7 people on our slow writing committee. Now, generally what that means is I actually write the slow, and then I share it with several other individuals, and it's are the clerkship directors, our MAEd fellows. We have our associate chair for education. We have our program director. So again, just getting a lot more people's input into that is hopefully one way to kind of get over some of that inherent biases that I have that I may not even be aware of. And then why bias matters. So there's the individual evaluations. Then you compound that with the grades, and then compound that with SLOs, the Dean's Letter, MSPE, the residency interviews, the match. Then again, so all these things can compound and really affect their future grade. So again, combating bias. So again, being aware of bias and educate your assessors. So again, doing the bias training, monitor assessment data for bias and stereotyping. describe actions, not qualities. So I think that, again, this was brought up, I saw you do X, instead of kind of the, hey, you should work on this, but say, I saw you do this, here's how you should work on and improve it. Rely on observations, not inferences. Kind of pause between hitting that submit button, asking yourself whether the assessment is factual, balanced, and constructive. We're kind of right on time, so multiple choice test. Again, they're thought to be easy, familiar, reliable, valid, but there are some cons. Only measure knowledge and summative. And again, even with the national data, there is bias that are built into a lot of these. Again, we've kind of gone over writing and presentations. Again, many options, providing insight and non-clinical skills, informative, cons, time-consuming, to grades, shift focus from clinical skills. So actually, so compensatory versus non-compensatory. This is where, you just kind of have, and this is kind of what we're moving toward, where you have to hit X mark, where you've got to do great on clinical care, you got to do great on your exam, you've got to do great on professionalism individually in order to get honors, maybe, versus versus compensatory, where your clinical scores might be fine, but you did great on the exam, so you'll kind of compensate a little bit for maybe a lower score clinically, or vice versa, where clinically everybody loved you. Again, you got really high scores there, but you didn't do as well in your exam, but because you did so well clinically, it kind of, that average kind of brought you up. So there's a couple different ways of doing it. So we are actually moving somewhat from the compensatory we are now to more of a non-compensatory one. And then setting cut points for grades. So there's a couple of different ways you can do that. HOFC, ANGOF, I think are the most common ones. That's what we've kind of used when we did that. And what we did is we said, okay, so the sheet that I showed you earlier, when we set our standard, is we actually said, okay, so for a second year medical student, because again, that's when they're coming through, what's the minimally competent, where would that student fall? Again, so that's like your minimum, so that's their passing, versus where does that exceptional student fall? And we had everybody write it on a sheet, and we literally went through it and said, okay, you said 2, you said 3, sometimes it was why did you say that? Other times we were just kind of looking at that average, and it kind of set those standards versus like the minimally versus the outstanding. And again, that's kind of your pass versus kind of your honors type range. So that's one way of doing it. But again, a lot of this is outside of our time frame for doing it. All right, so we went over a little bit. If people have any questions, I would just kind of jump all the way to this. So feel free to email me if people want to stick around, and I think a couple of us are going to be around still for a little bit if people have questions. Again, same sort of thing. People want to talk about boot camps, we can talk about that too, or drop me an email and I can connect you with some people that I know that are doing them. All right, well, thank you for your time.